this corona disaster. That if we are to survive as a species, scientific discovery should really be unrelenting. That innovation should be fostered in a way by which we can contextualize this in order to achieve better impact and relevance to our patients, the way we educate our future doctors, as what will be presented by Dr. Randy Abdullah and Dr. Tina Batak. Artificial intelligence and convoluted neural networks that will be presented by Dr. Nats Aureliasa. Improving diagnostics with digital applications by Dr. Alvin Caballas and Dr. Louis Gaston. Further understanding a Filipino disease, XDP or Lubag disease, to be presented by Dr. Emilio Villanueva. And last but not the least, better healthcare delivery models to be presented by Dr. Penny Bundok, and of course, from the Department of RLHNS, Dr. Philip Puliante. The breadth of the presentations this afternoon clearly shows how research is growing by leaps and bounds in the college and as part of the Inspire flagship program in the 2 remaining years of my term as dean. I just got some recent data from Diego here. From 2017 to the present time, we have around 72,607 citations for our researches. So that is about 34.2 citations per publication from the College of Medicine. CM alone surpasses Ateneo de Manila University in terms of the number of publications. We comprise almost 25% of all the research output of the whole University of the Philippines network. And I think that it's a testament to how we regard research as the basis for improving healthcare delivery and improving patient care for our countrymen. So with that, I am really very proud to be the academic leader of this college. And I thank you all, faculty members, for showing the way in leading research and evidence-based practice of medicine in our country. Maraming salamat po.
Thank you very much, Dean, for highlighting one of the important pillars in the college and as faculty, the importance of research in improving health, not just within the hospital, but in the country. And thank you also for sharing with us data on our outputs, on how we fare. Of course, how we benchmark with other universities. Okay. And of course, I'd like to thank our faculty presenters, congratulate them also for submitting their completed papers. And every year we do this as a forum for disseminating completed outputs. And we've also invited reactors to give us insights and perspectives on the completed papers. So to start off, as mentioned, so the first 2 papers is on health education, medical education strategies that have been developed. And in our research, in our recent agenda setting, this is one of the priority areas. We would really like to look at the acceptability, the effectiveness, the impact of the novel teaching strategies that we have created, especially during the pandemic. We've actually been planning it even before the pandemic. And I think the pandemic hastened the application of all these strategies that we've been trying to tell our faculty to get involved in. So we'll hear these 2 presentations, and I'd like to start off with the paper on integration of simulated thoracentesis using field-preserved soft cadavers in the teaching of anatomy of the thoracic cage for LU3 medical students, to be presented by a faculty from the Department of Anatomy, Dr. Abdel Jeffrey Abdullah.
Thank you, Associate Dean, Dr. Alan J. Good afternoon, Bichong, Associate Dean, Dr. Alan J. Colleagues, magandang hapon sa inyong lahat. This is the first time that the Department of Anatomy actually presented a paper in a faculty forum. The paper is about integration of disseminated thoracentesis using a field to serve cadavers in the teaching of thoracic anatomy to LUT medical students. This is actually the mother paper of our study, the DIP2. This study was conducted during our DIP2 program last summer. So in response to the COVID-19 pandemic, the College of Medicine of the University of the Philippines, Manila introduced a bridging program, the Learning Enhancement in Anatomy. This program was conducted by the Department of Anatomy, that was designed for first-year medical students and aimed to reinforce the knowledge and understanding of gross and correlative anatomy and histology that students acquire in a virtual environment. In the medical school's observation objective project adopted by the American Association of Medical Colleges, the goal was to develop a consensus within the medical education community on the attributes that medical students should possess at the time of graduation. Included in the MSOP was the recommendation that students have the ability to perform routine technical procedures, including venipuncture, arterial puncture, thoracentesis, lumbar puncture, inserting NGT, a Foley catheter, and suturing lacerations. Soft and bound cadavers. Human cadavers are increasingly being used as a model to train surgeons and anesthesiologists because they look and feel like real patients. A steel cadaver, however, is more expensive than the formerly preserved cadaver. But despite the high cost, steel embalmed cadavers are described as exceptionally lifelike. Now, the College of Medicine of the University of the Philippines, Manila, has an outcome-based medical curriculum with 10 learning outcomes. One of these 10 learning outcomes is clinical competence, which should include competence in procedural skills. These skills should include proficiency in performing a list of procedures similar to those of the MSOP of the AAMC. This study looks at one of those skills, thoracentesis, because this is a common procedure that is done for diagnostic and or therapeutic purposes for patients presenting with effusion. These are our objectives for this study, general and specific, just to highlight that we are to evaluate the use of field, soft, and bound cadavers for simulated thoracentesis by LUT students. The methodology, the simulated thoracentesis is just the last of the OS205 stations in the department's LIP. The soft cadaver is placed in a sitting position. LU3 students start with the study of the thoracic anatomy on a formalin preserved cadaver and end at the simulation station. CT scan and chest X-ray films of a patient with pleural effusion are shown, and findings are explained to the students by their faculty preceptors. The students are required to watch a video of thoracentesis performed by a general surgeon on a patient with effusion. The students then perform the simulation procedure on a field preserved cadaver. Now, the pleural effusion is actually filled on the cadaver is artificially created by pumping a colored fluid into the pleural cavity through a small incision at the second intercostal space at the level of the anterior or mid-axillary line. This is performed by the anatomy faculty member assisted by our staff. At least 1 liter of colored fluid is instilled into the pleural cavity. The faculty member then performs the thoracentesis to confirm the successful development of effusion. Ideally, it should be done by an ultrasound, but because we do not have an ultrasound machine in the department, the thoracentesis confirmation was done by our faculty members. The points of needle placement are then marked at the posterior chest wall along both scapular lines. At least 2 points of entry for the needle are marked on the chest wall. The students are allowed to do the procedure at least twice if the first try is unsuccessful. The cadaver is then made ready for the students for the simulated procedure. Now, before doing the procedure, The students are first asked to describe how to perform thoracentesis. Then they are allowed to perform the procedure. As shown here, the student is now performing the procedure and has successfully actually do a thoracentesis with the aspiration of the colon effusion. After draining fluid from the cavity, the student is asked to re-inject the fluid back into the pleural cavity so that the cavity will not be drained of any fluid. After each group of students is done with the simulation, they are asked to answer 6 Likert scale survey questions with a scale from 1 to 4 if they are in agreement or disagreement with the questions in the survey. And these are the results. As to the demography, there's an almost equal number of male and female students who participate in this study. Less than half of these students took a human anatomy course during their undergraduate courses. 22% are intermed students, 20% are BS Bio students, and the rest have different courses in their undergraduate years. Now, most of the students responding to the survey questions, 90% of the students strongly agreed that performing thoracentesis on a soft cadaver enhanced their understanding of the anatomical basis of the simulation procedure. 94.9% of the students also strongly agreed that the simulation procedure improved their understanding of the steps in the performance of the simulated thoracentesis. Likewise, 98% of students also strongly agreed that performing the simulation on field-preserved cadaver was an enjoyable and stimulating learning experience. 68% strongly agreed that they feel capable of doing the procedure on a cadaver. 97% strongly agreed that simulation procedure should be part on a soft embalmed cadaver should be part of the learning competencies of medical students. At least 80% agreed that they also feel capable of doing the thoracentesis in a clinical setting. Now, integrating procedural skills using simulation and utilizing soft-preserved cadavers early in the course of the medical education of our medical students may improve clinical practice and build their confidence and competence when presented with challenges of doing a procedure in a clinical setting. This simulation activity enhanced the understanding of the anatomical basis of doing the procedure and the steps involved in such procedure. This cannot, however, be achieved with one simulation session. Skills in procedures can be developed with simulation and with skills that are acquired by our students after doing them repeatedly in a soft field-preserved cadaver. We develop competent and confident future physicians. The use of models and mannequins will remain as training tools, and they will not be totally replaced by soft cadavers simply because of economic reasons. It is much more expensive to preserve cadaver by the field method. The main goal of the study was actually to develop the perception, attitude, and the potential benefits of doing simulation and field-preserved cadaver. In this case, a thoracentesis. We envision the use of a field-preserved cadaver to be an added clinical training tool to our anatomical models, mannequins, that would enhance the students' anatomical knowledge and provide an enjoyable and a stimulating learning experience. And perhaps with repeated performance of the simulation in a soft cadaver, they will also build their confidence in doing the procedure in the clinical setting. For our future physicians, this will all add up to promoting patient safety. This can be an outcome-based training activity for our medical students and is competency-based. This should be acquired by our students before they graduate from medical school. Once they become comfortable by doing it with repeated practice, they become competent doing this in a clinical setting, reducing the risk of complications and improving patient safety. To conclude, in our study, integrating simulated thoracentesis using a field-preserved cadaver early in the course of a student's medical education provided students with a better understanding of the anatomy of the thoracic wall and the anatomical basis of doing this simulation procedure. This model can be considered by anatomy educators as an integrative learning activity when teaching thoracic cage anatomy. This can likewise be extended to senior medical students and residents across different specialties. Thank you.
Thank you, Sir Randy. Swerte ng medical students ngayon. Okay. So we'll have the reaction and questions after the second talk. So now let's listen to the paper on the effectiveness of a 3R online dermatology didactic course on the dermatologic knowledge of Dr. Sudabarrios, a quasi-experimental pilot study to be presented by Dr. Maria Cristina Filomena Batak from the Department of Dermatology.
Good afternoon, everyone. We have thought it serendipitous that we have been given this chance to present this study on the centennial year of the Department of Dermatology. The theme of this year's Faculty Research Forum is Advancing Research through Collaboration, and this research fits the theme since this project would not have come to fruition without the cooperation of the Department of Health, Health Human Resources Development Bureau, and the many UPPBs who participated in the study. Our study is entitled The Effectiveness of an Online Basic Dermatology Didactic Course on the Dermatologic Knowledge of Dr. Sudabarrios, a post-experimental pilot study. I was the supervising consultant advisor for this study. The principal investigator was Dr. Diane Salazar Paras, our current chief resident, who is with us today. And the co-investigators were Dr. Raisa Rosete and Dr. Doha Relis Manalo. Dr. Paras has presented this in several research fora, and Dr. Doha Manalo will be presenting this tomorrow in the Residence Research Forum as well. There are currently 1,281 PBS board-certified dermatologists. These skin experts cater to 109 million Filipinos, according to the latest population census. Therefore, at present, there is only one dermatologist for every 85,000 Filipinos. This ratio, however, is an overestimation for most rural communities because not all of these board-certified dermatologists are in active practice. And most active dermatologists are practicing in the cities, particularly in Metro Manila, where the ratio could be as good as 1:19,000. Unfortunately, this ratio could be as poor as 1:4.4 million, as in the case of the ARM. Thus, for their dermatologic concerns, majority of impoverished Filipinos depend on the free services offered by government-employed primary care physicians including rural health physicians, municipal health officers, and doctors under the Doctors to the Virus program. These TPPBs are deployed by the DOH to the geographically isolated and disadvantaged areas of the country. Currently, there are 392 active DPPBs who act as the frontline skin doctors in their respective areas of assignment, where access to dermatologists is limited, if not almost impossible. Unfortunately, majority, if not all DPPBs, are general practitioners who might rely on the dermatology rotations they had while in medical training, which are currently not standardized across different medical schools. We therefore ask the question among the DPPBs who are currently deployed in various areas of the Philippines, is an online basic dermatology didactic course effective in increasing their dermatologic knowledge and their confidence in the diagnosis and management of common skin diseases? To answer this research question, we aim to determine the baseline knowledge and confidence level of PPPBs in the diagnosis and management of common skin diseases and the effectiveness of an online basic dermatology didactic course in increasing their knowledge and confidence level using timed 25 item online pre-test, post-test, and detention quizzes administered before, immediately after, and 1 week after an online basic dermatology course. In addition, we aim to determine the commonly encountered skin diseases in the community, the referral practices of DPPBs to dermatologists, as well as their dermatologic training needs. An email invitation was sent to all 392 active DPPBs in coordination with the DOH. Attached were the detailed informed consent form as well as the link to the online registration form. The registration form was kept open for 2 weeks before the scheduled online basic dermatology didactic course was held. A quasi-experimental before and after study was conducted with the volunteer DPPBs from August 28 to September 4, 2021, following this timeline. The pre-test was administered to all participants before the start of the 3-hour synchronously delivered basic dermatology course. The post-test was administered immediately after the course. The lectures were recorded and the participants were given access to the recorded lectures from August 29 to September 3. Finally, a week after the course, the retention test was administered. The basic dermatology course delivered to the DPPBs was composed of 11 modules, which were patterned after select modules from the American Academy of Dermatology online or dermatology curriculum. These modules have undergone several reviews and revisions by a consultant dermatologist and were delivered live to the DPPBs by 2 senior dermatology residents through the year. Dermatologic knowledge, specifically in the diagnosis and management of bacterial skin infections, dermatophyte infections, acne vulgaris, psoriasis, seborrheic dermatitis, and superficial yeast infections, and their knowledge on the cutaneous manifestations of COVID-19 were measured by a 25-item clinical photo exam. And the DPPBs were asked to self-evaluate their confidence in their ability to diagnose and manage common skin diseases using a 5-point Likert scale, with 1 as very poor and 5 as very good. Items to answer the other objectives were also asked in the question. Among the 392 active DPPBs who were invited, 149 volunteered to participate in the study, and among them, 140 were able to attend the dermatology course. And from these attendees, 94 were able to answer both pre-test and post-test. A week later, 97 DPPBs answered the retention test, but among them, 16 were excluded from the quantitative analysis because they had no paired pre-test and post-test scores a week prior. Finally, only the scores from 81 DPPBs who completed the pre-test, post-test, and retention tests were analyzed. A repeated measures ANOVA showed that the mean scores in the pre-test, post-test, and retention tests significantly differed between the time points. The DPPB's dermatologic knowledge, as measured by their clinical photo exam score, significantly increased after attending the dermatology course. A repeated measures ANOVA showed that their confidence in the diagnosis of skin diseases differed significantly between time points. The DPPB's confidence in diagnosing common skin diseases significantly increased after attending the dermatology course, and their confidence in managing common skin diseases showed similar significant results. According to 63% of the participating DPPBs, About 10 to 30% of the patients that they see every week are consulting for a primary dermatologic complaint. And top 10 skin conditions that are most commonly encountered by the DPPs are the following, with bacterial skin infections, allergic contact dermatitis, and scabies on top of it. Almost 60% of DPPs have not referred a single patient to a board-certified dermatologist in the past 30 days. And whenever they encounter difficult dermatologic cases in the community, most direct patients to the nearest tertiary hospital, or they refer to a friend who is a dermatology resident in the PBS accredited dermatology training. Lastly, congruent with the most encountered dermatologic cases, bacterial skin infections and scabies infestations belong to the top list of topics that DPPs would like to learn more. In conclusion, an online basic dermatology didactic course appears effective in increasing the dermatologic knowledge of DPPs, as well as their confidence in their dermatologic competency. 3/4 of the DPPs do not know the PBS board-certified dermatologists that are practicing within their regions, and thus the referral rate to these specialists is low. And DPPs would like to receive further training regarding common skin conditions in their community. Our study highlighted the gap in the healthcare delivery system. The PBS, as a dermatology specialty society in cooperation with the Department of Health, may generously fill in this gap by providing supplemental support to the DPPs and other government-employed primary care physicians, either through educational intervention, through teledermatology, which we are already doing, and a dermatology ebook dedicated to the primary care physician as requested by the DPP. Furthermore, the PBS may establish a formal communication network between the DPPs and PBS board certified dermatologists and PBS institutions in respective regions. We aim to reach out and fill in the identified gap in the healthcare delivery system by forging a strong partnership with primary care physicians to deliver quality dermatologic care to all Filipinos, regardless of their capacity. This study was carried out last year, and among our recommendations, 2 projects are now underway, and these include essentially a similar project, but this time with the support of the Philippine Dermatological Society and primary care physicians from Antipolo, Pasig, and Angeles, Pampanga. These are the target participants. Other PBS training institutions are part of this project, such as East Avenue Medical Center and Rizal Medical Center. And the goal is to make these modules eventually available to other institutions so that they can each train primary care physicians within their catchment area. The other study is an evaluation of the dermatologic diagnostic skills of DPPs participating in the PGH teledermatology referral system. The premise is that the teledermatology referral system, aside from facilitating referral of cases DPPs may find difficult to diagnose, this may improve the diagnostic skills of DPPs and therefore improve patient management, especially in areas far from specialty care. We hope that this project, though like a drop in the health system, continues to cause a ripple effect that by improving the dermatologic diagnostic skills of physicians giving primary care in the front lines, we are able to make a difference in the lives of more of our people. These were the DPPs who generously shared their time with us by participating in our study. And these are our lectures.
Thank you, Tina. Now let's hear a reaction from Dr. Hazel Manapat Reyes, who is the head of our medical education unit and assistant to the associate dean for academics. Hazel, let's
Yeah.
hear from you.
Good afternoon to everyone. I'm sorry I could not join you. We had a family emergency. Anyway, first of all, congratulations to Doc Randy and the Department of Anatomy and Tina and the Department of Dermatology for presenting such beautifully prepared papers. I think they have set an example for that, for seamless integration of research in medical education and training. I was inspired by what they have done because it shows that research does not have to be a separate, painless process from what comes more naturally to us, which is actually teaching. The study of Dr. Abdullah and the Department of Anatomy is actually a very good prologue to what we want to do with the virtual simulation laboratory that we are opening, no, within this year under the leadership of Dr. J.J. Hermar, because they've already been able to see how well simulations can complement instruction in the basic sciences. And this is really the perfect example of putting the clinics into the basic sciences, which is something that we've always pushed for with our OBE curriculum. Tama si Dr. Randy, no, na these are competencies that we acknowledge are important, but sometimes we think of thoracentesis and such procedures or terminal competencies, when in fact we can use simulation to stimulate student interest and put relevance into what they're learning. So to them, it's no longer just a matter of memorizing anatomic structures, but they realize that, this anatomic structures really have a sense in terms of why they need to learn them and how they would apply them in the clinical year. So thank you for that, Dr. Randy. I think that would be a very good model for us as we start our virtual simulation lab on how we can um, rapidly assess how it impacts and how this exercises impacts into the learning of our medical students. For the paper on equipping our DPPDs with further skills of teledermatology, I was so impressed kasi talagang ito yung perfect na teaching, research, and extension service, di ba? Parang lahat ng mga boxes dun sa form natin as faculty are ticked by this program. It's a good reminder for us as well that when we do programs, extension programs, there are also opportunities within that to see how well we've done the program and how these programs have an impact into the training of our specialists or of our primary care physicians or specialists, and how it would potentially impact in terms of patient care. I think, Tina, no, you were mentioning that the next phase is really going to look at how it will affect the way that they refer patients in terms of the clinics. No? So it would be interesting to see both those papers as well. So both of these papers sought feedback from our students and our trainees immediately after training or soon after of the teaching learning experience. It would be nice to see if we can follow through with the students who had this kind of experience in to see how long ba yung kanilang confidence mareretain in terms of uh, procedural skills, clinical procedural skills, and how they would impact into the way that they actually do these skills when they go into the clinic. For that same matter, I'm glad that the project of DERM has subsequent phases, because that would tell us really kung ano ba yung long-term effect ng mga efforts natin in terms of training. Well, I hope both papers become models for all of us in the UP College of Medicine on how we will be able to quantify, no, in the immediate and in the long term, the effect of what we do as medical teachers. So again, congratulations to Dr. Randy and Dr. Tina and the departments of anatomy and dermatology for pushing the envelope in terms of research in medical education. Thank you, Isa. Thank you, Dean.
Thank you, Hazel, for highlighting, no, the important points in the research papers and how we can move forward also, no, these prototype researches, no, especially since we're really harnessing, no, technology to improve teaching and also to address the gaps in health service delivery. So With that, I open the floor for any questions. Yes, Ronnie.
So congratulations to the two presenters, especially to Dr. Abdullah and co-faculty. My question is for Dr. Batak. Ma'am, I really enjoyed your presentation. I mean, being in the field of neurosurgery, we also have to deal with the same thing. There's really lack of standardization in neurosurgical education, and there's a lack of these doctors to the bars. They also face neurosurgical consults, and many of them might not have had neurosurgical training that they or exposure to be able to manage, for example, conditions such as hydrocephalus, spina bifida, or trauma. Now, my question for you is this: because dermatology is really very visual. During the conduct of your course, did it matter, for example, the technological requirements? For example, the brightness of the screen, the contrast. How did you account for those differences? And I suppose my comment is this: I think uh, I would really suggest that you put these modules up maybe on YouTube or freely available. So as you said in your presentation, your dermatologic education is not standardized. And I feel that, for example, if you put these learning modules and put them up online, freely available for medical students, I think that's another research, something you could look into. Thank you so much again.
Yeah, thank you very much for the question as well as for the interest in the project. We didn't take into account the the way the pictures will be seen by the participants. Yeah, so we didn't. Yeah, but there's still nothing compared to actually seeing the patients.
But you
That's
felt that it did not matter much.
Yeah, it seems that there is still improvement in the diagnosis,
All right. Thank you so
in
much.
the diagnostic skills of the DTPs. And then the other one is a suggestion on uploading. We will consider that, highly consider. Thank you.
As a reaction to Dr. Reyes Heiser's comments, actually, I failed to mention the limitation of my study. Uh, the study was not done at different intervals, only one. So you don't know actually how confident they will remain after one single session. We also did not, I also did not go into correlation between doing it in a cadaver and doing it in a clinical setting kasi kulang ng time. And following that, we're actually considering also doing a simulated pericardiosynthesis as well as very functional real soft amount cadaver. Because I've tried the model, ibang-iba ang feeling sa model, malitin natin, when you do venipuncture, ibang-iba ang feeling than when you do. So we're going to try now to preserve a field preserved cadaver that will be used for venipuncture. A tip pericardiosynthesis, we're going to explore that. Thank you.
Thank you for that. No, I think the limitations, since you have the LEAP program, that can be addressed. No, it's part of maganda. Actually, I would like to commend Department of Anatomy for having that LEAP program. So from there, kasi you can really have an ongoing evaluation of the different simulation, the strategies no, that we are doing in anatomy. Kasi as you know, nung time kasi natin, like ako hirap na hirap sa anatomy. So now, with this technology, no, we really would like to document how effective it is no, in enhancing the skills and then eventually patient safety nga yung overall goal naman natin. So I think it's Jotec who led the youth program. So we can build on that. No? Alvin, yes?
Isa,
Yes, Hazel, sige.
Yeah.
Hazel.
isang pwedeng isang comment pa no. I remember kasi Dr. Pipo, ang sinasabi niya palagi pag LU3, very important yung wow factor, no? That's something else we can look at as we do these simulations. in the early clinical years, no, how much they're able to stimulate interest among our students, and what all of these interests will, how this interest will translate in terms of the way they move forward with their learning process. So thank you, Dr. Randy, for starting this off. We look forward to hearing more from your experience in the Department of Anatomy.
Yeah, in the next research fora and hope to you can see publications also. Yeah.
Yes.
Yes.
So first of all, thank you for the two amazing presentations. My question is for the first one, amazing Randy. So Randy, we all know that in fluorosynthesis, we aren't just concerned with taking out fluid. We are also concerned about not hitting anything else, right? So how are you, how is that simulated? You don't puncture a lung, for instance. Over.
It's a cadaver. So it's always most likely collapse. Therefore, the students will just hit the fluid. And once you hit the fluid, they start draining. So really, we cannot assess unless we start using, we actually tried putting both lungs under respirator. We can actually expand them. So maybe in the future, when the patient is put on a ventilator with the lungs expanding in anatomy, and we artificially create pleural effusion, then perhaps during that time we can assess how we avoid complications like pneumothorax or at this point, hindi namin kaya. Thank you, but thank you.
And okay, to dermatology then, congratulations. And I think the points raised by Ronnie on how we can expand the application and then sustain. I actually have the same questions. What were the obstacles or barriers that you encountered in carrying out this online didactic, for our doctors to the barrios and then
Initially, the project was supposed to have been carried out face to face, like not really online, but because of COVID, we had to do it that way. But in the end, it was actually still a happy, a fortunate event since we lessened on the um, other like expenses related with travel, etc. And we were able to actually reach out to more people because originally the project was supposed to only target RHU physicians in a certain province. But because of COVID, we had to rethink the project. We did it online and we were able to reach out to more people. The thing is, we also had to coordinate with the DPPs on their like we actually had to also rethink as to whether we should give it synchronously only once or do we have to make it available to everyone for a certain period of time, and we decided that it be available for a week instead of just giving it once because some DPPBs weren't available on the day of um, on the day that we gave it synchronously. So that was how we made up for that. I think that's one of the technological barriers that we had to face because some of them are assigned in isolated areas and they only get to be connected to the internet or with good internet when they go to the cities.
then maybe to it help sustain through bring it to the Department of Health as well, no, so that they can carry it on, to help as part of universal healthcare actually. That's, So thank you and congratulations to the impressive papers, first two papers on health education strategies. Now we move to the next set of papers on, again, it's technological innovations as well. No? So we have AFAR, a real-time vision-based activity monitoring and fall detection framework using ID convolutional neural networks to be delivered by Dr. Nats Orellasa Jr. from the Department of Orthopedics.
Thank you, ma'am. I know the title is so non-medical. Kahit ako, it gets me confused sometimes trying to read it. But it's my privilege to present AFAR, a real-time vision-based activity monitoring and fall detection framework using, ito yung medyo mahirap intindihan, 1D convolutional neural networks. And this is on behalf of our primary author, who is Engineer James Suarez, and our senior supervisor, Professor Cosmo. I have to give a clear disclaimer that I am still primarily a clinician, so I really relied on their expertise to understand this. And while this is still not in the clinical phase, I thought of submitting this just to raise awareness that these kinds of studies are actually possible now. So my involvement here was through the collaboration that was facilitated by UPCM with Prof. Prosnoval, who I think is also Sir Alvin's collaborator for his research, who is from the Computer Vision and Machine Intelligence Group. And we tried to identify some important problems in the field, and we looked at fall. So fall remains to be an important cause of morbidity and mortality worldwide. According to WHO, it ranks second, second in the cases of death due to unintentional injury. That as many as 684,000 die from consequences of fall. That happens mostly in the low and middle income countries. Just as relevant is the problem of sedentariness. And we're connecting this because the technology can actually identify both or work on both. So it's already an ignored pandemic. It is also about 5 million preventable deaths. It affects both the young and the old. And given these statistics, we recognize the need to better monitor activity and detect or prevent falls if possible in the most effective way possible. So we are clear on the need to monitor, and we see this everywhere. Our phones, our watches, smart watches will have some way of monitoring our activities. But we also have to admit that the problem is that many of these, even those that are not so reliable methods, still require a lot of resources, both in terms of technological infrastructure and human resources, which makes it a bigger burden for those who need it most, like at areas with low resource. So computer-assisted activity detection, including researches on reporting unobserved falls, has been an area of interest for scientists for many years now. Unfortunately, many of the available applications are still not easy to integrate or use in different settings, and many require more sophisticated computers, both for training and testing. So our study aimed to develop a framework primarily to detect fall and to monitor activity that is accurate and efficient, and it would be enough to be clinically useful, which may also be able to send real-time feedback to avoid delays in necessary management, especially in cases of fall, and to ensure usability in many centers, which means it should be compatible with low-end devices. So the methodology included using shared data sets available online and separately developing models specific for either activity monitoring and fall detection. Part of the optimization is determining the number of frames, which is translated to computing the need for the computational power need. And from the video clips that were analyzed to identify the activity, and to do these tests using a regular CPU, a regular computer that most of us will have access to without the need for what's called a graphics processing unit, which is essentially just a more expensive hardware for processing videos. But to give everyone a brief background on convolution neural networks, so in deep learning in AI, a convolutional neural network, or CNN or ConNet, is a class of artificial neural network most commonly applied to analyze visual images, such as in our project. CNNs use relatively little pre-processing compared to other image classification algorithms. This means that the network learns to optimize the filters or the kernels. Essentially, those are the ones finding the pattern through an automated learning. Or in short, there's independence from human intervention, as opposed to those that are handcrafted and you have to rely on what the human programmer instructs. So CNNs have become the de facto standard for various computer vision and machine learning operations. And to better understand the unique features of our framework, showing here illustrations of the different types of convolution neural networks. A 2D CNN in the middle is the standard CNN. And it's called two-dimensional because the kernel or the filter slides along two dimensions on the data, which is something that we can understand from an image. Now, 3D or conv 3D, the kernel slides in 3 dimensions. So in the medical world, we can probably understand it if we want to analyze a 3D image like that coming from a CT scan or an MRI or videos. They may also be analyzed using a conv 3D. Now, it may not be intuitive to imagine how an image can be 1D or one-dimensional, but this is achieved by following how a single point that moves over a time series is essentially evaluated. So a classic example, for a person who's wearing an accelerometer, we all have in their phone, able to collect data on the movement of the point in 3 different dimensions, but it can easily get that data for every direction and then do the analysis later instead of trying to combine all of them right away, which requires a computational power. So essentially, this affords a less taxing computational requirement, making it ideal for low-end computers. To visualize what I tried to explain, here we see how a program identifies points and follows the movement of points to label activities. I'm just showing first activity, and then there will be, you see, it's getting a little confused, but eventually it settles and it identifies the type of movement that or the activity that the person is doing based on those points, the moving points that are being identified. It's also similar for fall. So essentially, all the AI has to identify is if it's fall or no fall. So when the points move to the right direction, it's identified as fall. So the general framework involves a pre-processing or extracting the post through the points. And for this study, we used MediaPipe, which is an open source platform, customizable learning solution that was made by Google. So this is what's usually used for easily adaptable for post estimation. The movements of the points determine specific skeletal features, which are then used to create models. And the models are then tested against data sets that are available also online to establish the accuracy of identifying the activities. So this table summarizes the performance of the models with respect to the number of frames plus the features and their achieved accuracy, precision, recall, and F1. F1 is just trying to account for precision and recall. So it's like a summary metric. There were 3 data sets demonstrated in the full paper, but I'm showing just examples. One for activity detection, one for fall. So in table 1, we see that the best model, with respect to individual metrics, have outperformed previous studies as shown on the bottom. The best performing models based on precision and F1 is the model that uses 8 frames and all of the features, the point, the distance, and velocity. Meanwhile, the best in accuracy is the model that uses 4 frames and all features. And the best in recall is the model that uses 4 frames with key points and distant features only. In table 3, for identifying for the model that used 16 frames with all the features has attained the best accuracy, precision, and F1 score, besting the other studies, except in recall, but the number is really not that far apart. So our results have shown that first, our framework outperformed previous work on various relevant data sets. And we know that it's sufficient enough to run on a low-end device, which is what we use for experimentation. And in looking at the pattern between the number of frames and action, we have seen patterns of shorter frames that are already appropriate or enough for simpler actions. But for more complex actions like fall, we actually need longer, or the AI needs longer frames to analyze. Between features and sequences, we have shown that distance feature only is okay for shorter sequences, but velocity features are essential for the longer sequences. And combining all of these features with post key points provided the best performance. So what's next? Of course, we want to continue to improve this, and we're trying to find a simple model that can handle both simple and complex action. But at the moment, at least we know that they're working. And we want also a system that will be working because all of our models use a single person in the frame, we want to hopefully develop something that can be used in a room with multiple people, but focusing on one subject. And we also want to be able to test this in our local data, local setting, still in simulation, sa clinical. Then eventually in the clinical, we want to integrate this in monitoring device. It's actually part of an umbrella project that we're doing with CBOL. So I'm showing here my Beshi, one of our other projects, and we've been eyeing to actually integrate this as part of my Beshi's function to monitor patients in the ward. And of course, we want to be able to eventually pilot this in the clinical environment. So if you want to read more on the details of the study, I don't know who would want to, but if you want to, it's available online. Scan, and you may always contact us if you have questions. Thank you.
Thank you, Nats, for sensitizing us on this type of technology. I'm sure there will be questions. So let's hear first from a second presenter for this session, the digital histologic image analysis system for the diagnosis of Hirschsprung's disease by Dr. Alvin Caballes from the Department of Surgery and Social Medical Unit.
Good afternoon to the esteemed academic leader, faculty, and trainees and staff of the College of Medicine. I am both honored and grateful for the opportunity to deliver a talk on this topic. I have no conflict of interest to declare. My talk will center on a PCHRD supported project. It is formulated for the following objectives. The areas to be covered are as listed. Now, 6 years ago, I received an email to invite me to an event hosted by the PBDIC. The consortium is essentially a technology incubator meant to bring together different stakeholders and facilitate the translation of new concepts into the market. Having been frustrated with long waits as well as occasional imprecise histopath results, not from our pathologists, of course, and their adverse consequences on patients, I chose to make the case for a better diagnostic system for Hirschsprung's disease. In keeping with the consortium's whole package approach, I asked for a new device wherein one can simply put in a glass slide in one end, and the built-in computer will quickly churn out the diagnosis at the other. To my pleasant surprise, several engineers from 2 other universities approached me and volunteered to help out. Before long, I was also able to convince Dr. Mark Ang, who will be presenting later on, from pathology to join the team. Over several weeks, we were able to cook up a protocol. We had one main ingredient missing, however. We did not have a digital image analysis expert. We secured a balik scientist grant for a US-based Filipino scientist with the expertise, but the scientist did not come as arranged. The project had seemingly reached a dead end. Sometime in 2018, I got to meet Dr. Pros Naval, as also referred to earlier, a professor of computer sciences at UP Diliman. In this video grab, he is the diver on the left, setting up an underwater camera system. This is another screen grab of what he can do with this imaging system. Any fish that comes into view gets to be identified by the program, and the estimated weight is also displayed. I, of course, thought that if he can have a computer system do this for fish darting in the ocean, he probably will be able to identify stationary cells in a glass slide. Dr. Naval was also discerning enough to point out that the effort should focus first on the software and also be of use primarily by pathologists. He brought in his graduate student, Martin Nabus. Dr. Ang persuaded Dr. Anthony Macali to also join us. In the late 2019, we were able to obtain a PCHRD grant, and the effort was rekindled. The problem that we wanted to deal with is not trivial. The burden of Hirschsprung's disease is significant with its higher incidence in Asian countries. We also currently know that it is an intestinal neuropathy and not amenable to medical treatment. We consider it a surgical disease as patients afflicted with the condition will require now standard surgical interventions. Nonetheless, for the definitive surgery to be appropriate, effective, and even safe, we are very much reliant on correct and timely histologic evaluation. The absence of ganglion cells is a sine qua non for making the diagnosis. There can be other supporting histologic findings such as neural hypertrophy. These need to be arrived at using intestinal biopsy specimens processed by either frozen or paraffin block sections. These techniques have their intrinsic advantages and disadvantages. The actual interpretation of histologic specimens can be challenging, however. As such, other approaches have been developed, including the use of immunostains. Nevertheless, significant constraints remain, more so where pathologists' expertise and laboratory resources are limited. All these beg the question of whether better ways can be considered, particularly by way of computer-based technology. Of late, digital modalities have been gaining ground in pathology. There are already, for instance, commercial systems for the automated histologic diagnosis of breast cancer. All these considerations went into the planning and implementation of our project. The efforts that went into this are summarized here. The surgeons identified the cases, the pathologists retrieved and post-processed the corresponding slides. Digital images were taken and ganglion cells, when present, were annotated. The computer scientists, in the meantime, worked on the algorithms for the image analysis software. Unfortunately, with the pandemic having set in, access to the PGH lab and even the computer servers at Iliman were restricted. Likewise, elective surgeries, particularly those requiring closing sections, were deferred. After a few months pause, the work was resumed. The annotated digital images were transmitted to the computer scientists. By means of machine learning, the capability of the developed software was repeatedly enhanced. Eventually, the software was able to exceed even the set diagnostic threshold. All the interest and care for the afflicted patients would not have been possible were it not for the physician who had first thoroughly described the condition that now bears his name, Harold Hirschsprung. We have therefore called our system Harold X. The trademark rights for this is being worked out with the help of PTBDO, following their assistance with the system's patent application. The software is currently installed in a server at the Department of Pathology of the UP College of Medicine. Here's a screen capture of the user interface. The program has just been asked to start working on a signal image. A previously inputted unmarked file is searched for using the browser. By clicking the upload button, the selected image is instantaneously displayed. The software has already annotated with blue boxes the areas containing the ganglion cells. Likewise, as you can see at the bottom of the image, the count of ganglion cells in the field was automatically generated. The system can also process multiple images. Here, the program was asked to analyze 11 images. As the images in this instance were remotely transmitted to the computer, it took about 2 minutes before the annotated images could be made available for viewing. This could be consecutively viewed, again with the ganglion cells marked out and counted. When the idea for all this was conceived years ago, and even when the research proposal was initiated 3 years ago, there were no prior reports on the topic. There have since been 3 publications that have demonstrated the potential of IT-based diagnosis of Hirschsprung's disease. We submit nonetheless that the software which our team developed is just as groundbreaking. Our work is still but the necessary first step in eventually arriving at a fully automated diagnostic system. We have recently received another PCHRD grant to expand the functionality and utility of the system. I hope, however, that it is evident that a big step has already been taken. Our team was not sure if we could be able to come up with a usable system when we started out. The pandemic brought added uncertainties. Now we can anticipate that we can be of assistance to any center in need of diagnostic confirmation of Hirschsprung's disease, subject only to the availability of an internet connection. We hope to extend the technology to other disease entities as well. We will help pathologists, help surgeons to better serve patients. Again, I am grateful for having been given the opportunity to deliver this talk. And I would especially want to thank the pathologists, computer scientists, and surgeons who helped make our work possible.
Thank you, Alvin. So we're seeing how to harness the power of computers and software in the field of medicine through collaboration. And then we'll hear another one on hand gesture controlled operating room imaging console to be delivered by Dr. Zar Louis Gaston, again from the Department of Orthopedics.
Thank you. Thank you, Dr. I'm privileged to be speaking in this forum, both with two other surgeons who have done collaborative work with engineers. And this work is on developing a operating room imaging console. So my name is Louis Gaston. I'm an orthopedic oncologist. I deal with bone and soft tissue tumors. And part of my work is to remove the diseased bone or soft tissue. And in something like this, then we try and save the extremity of this patient. We base most of our work on imaging. And as you can see here, with our MRI scans, we can know roughly where that tumor is. And with careful planning, we apply that intraoperatively so that we can remove the tumor with good accuracy so that we have safe margins. And in something like this, it's very easy to plan the operation because it's 2D, length and width. But with something much more complex, like this proximal tibia tumor, where our cuts then become not just perpendicular to the bone and the joint, where we start to get what we call geometric cuts, then the surgery becomes much more difficult and complex. No? And we often have to go back to our imaging as we do these procedures to make sure that we're doing it properly and safely. This is usually our setup. We do our operations, and at the moment, our imaging is based on what we call negatoscopes. So we have X-rays put on one side of the room, And we look at it from time to time to make sure that we're doing our surgery properly. That's with an X-ray. With an MRI, it becomes much more difficult, especially if it's a printed MRI. So we go close, review what we do, make sure that we do it properly. If you're lucky and your resident brings a laptop, then you can, that laptop is used to review the imaging. Doesn't look very safe. How important is essential imaging? When, as part of the WHO surgical safety checklist, no, before we cut, no, the nurses always ask us, is essential imaging displayed? That stresses the need for having this available when we do our operations. And indeed, there are studies that suggest, no, that imaging problems during an operation have been shown to lead to adverse outcomes. It doesn't matter how good we are as surgeons, no? If we have prehistoric tools to help us do our jobs. And then so we thought of coming up with a solution. So something that we could access in the operating room with a wide screen so that the imaging would be easily be visible to us, no? Mobile, so that you can move it around the operating room environment, so that the surgeon would not have to walk towards it or look around so much, no? We want something to be able to access digital imaging properly, no? Unfortunately, even in PGH, no, we have a PAC system, but there's nothing in the operating room where we can use to access it during our operations. But most importantly, no, we want to be able to, as surgeons, no, we want to be able to access and browse these images, no, ourselves. Quite hard to do while you're sterile, no? So we thought of doing this via touchless modes, no, without breaking our sterility and without having to ask our residents or nurses to do it for us. In collaboration with the UPCM program, we talked with engineers from the Department of Engineering in UP Diliman to come up with a prototype device with all of these needs. So basically, the device has a camera which detects hand gestures. And once it detects the gestures, then it triggers the program to go through the uploaded medical imaging. So we came up with a prototype device and tested this with PGH operating room personnel. And this is roughly how it goes. So we are able to browse imaging from a distance of about 1 meter or about 3 feet, and using just hand gestures, we are able to go through the images on the system. So we tested this on 17 PGH OR personnel in a simulated setting. Personnel, surgeons from ortho, GS, TCBS, ENT, and some OR nurses, no? Personnel who we thought would be using this device potentially in the OR setting. And we timed some of them to see how long it would take them to go and use the device, and roughly, no, about a minute and a half to browse images in 3 views, no? So axial, coronal, and sagittal. We asked them what they thought about the device using a system usability scale questionnaire. And most of them said that it was easy to use and that they thought that they would use it frequently, given the practicality of having the said device in the operating room setting. However, they did stress that they would need training to use the device and that they would need tech support while doing it. No? I forgot to mention that before the testing, no, the participants went through a demo, a 30-minute demo slot. What else they think about the device? They thought that it would be practical and convenient to use at the OR, given the present imaging capabilities. The hand gestures themselves were also quite simple. However, they did note some inconsistencies in the detection of the gestures, as well as some lags in the response. No? I think these are quite easily remedied, no? with further testing and tweaking of the software. And probably the most important is that it lacked some plug and play functionality. The possibility of having a technician on the side with the present prototype. What were the possible improvements that the participants brought up? The possibility of using voice prompts to turn on the device, as well as improving the working distance. Now, at the moment, the camera is only able to detect gestures from about 3 feet, which is safe, no? But if the surgeon on the other side of the operating table would want to manipulate the images, then he would have problems. What are our future plans with the prototype? Obviously, we want to improve the design. At the moment, it's quite bulky. No? The screen could be bigger and improve the functionality as well. No? Make it more responsive to the surgeons using it. We also want to improve the training manuals and materials available to be able to train surgeons to be using this. No? And finally, to be able to test this in the operating room setting here in PGH and in outside hospitals as well. Thank you very much.
Thank you, Louis, Nats, and Alvin for showing us how to create and innovate through collaboration and to give us insights and reactions, no, on this three impressive collaborative work. We have Dr. Iris Isiptan, the head of our medical informatics unit.
Good afternoon, everyone. I'm so happy to be here and to be hearing about these researches, and I hope that more faculty will actually do work in this area. So I'd like to congratulate Dr. Aurelias, Dr. Caballes, and Dr. Gaston. And it was pointed out that they are all surgeons seeking as an internist. So let's go with the comments. So first, I'm very glad that Dr. Aurelias was able to explain to us what a convolutional network is. If you spend more time looking at it, it will become clear, I assure you. So my first question for Dr. Elias actually is, where did you get the UP-FOL data set?
There's a reference in the slide. It's available online. It's University of Panamericana, hindi UP.
Hindi UP, UP.
Confusing sa yung UP. It's available online.
Okay. So thank you.
Nalito din ako, ma'am, nung simula.
So I asked that question because I have met Dr. Prosnaval previously in some conferences, and I think he was saying that since the Data Privacy Act, they've had difficulty getting data sets And he knows that we have data sets. Now, what's the problem with our data sets would have to make sure that they are de-identified and converted into open data sets that can actually be used by everyone. Previously, Dr. Leo Selly was here and he helped put up the MIMIC database. So the MIMIC database is actually a database of clinical data of patients in the ICU that they have de-identified and they have made available to all. What's nice about that, Dean, is when somebody uses that data set, they will have to cite Dr. Leo Selly and the people who actually put the database together. So that's why I was very interested where Nats got it. And I was excited it might have been the UP, but it's University of Panama. Okay, so hopefully we can have a data set like that. The other thing would be when I look at these papers, because we are clinicians, we always ask about what is the application. And buti na lang, I attended the dementia conference. So I learned about smart environments and how we need to protect, for example, the elderly. So one of the things they look out for is falls. So what happens is if you have some device that detects that one, a patient is not moving or a patient has fallen, then the nurses can actually go to that particular room because we know that staff workforce is usually limited and they can't be watching all the patients one by one. So, so I was just wanting to share that the future application of this thing that NATS is trying to do is very important if we are able to do that. Okay. So if we contrast that now to the second paper of Dr. Caballes, I'd also like to say that one of the advantages of having the convolutional network is it doesn't require a lot of pre-processing, meaning they just use the data set and try to make their framework. Because if you recall in Dr. Caballes' study, they had to label the slides. You had to say, this is a ganglion cell. Is that correct, Dr. Caballes? Yes. So imagine they had to do 500 something slides, which they divided and came out with 3,000 something images, and that is called the training set. So, but as you saw, we were able to develop the software that actually can do the reading automatically now based on that. But I can just imagine the blood, sweat, and tears the pathologist had to go through to label all those images. And so because I was talking about open data sets, my next question would have been, what are you going to do with those images? How can we add some more to those images? Because people are always looking for training data sets. Yes.
Well, thank you, Iris. First of all, I think, Mark, ano, they work with 50 slides and work on those slides, which can be many, many images. And with the many were extracted, then the computer was able to chop it off in, again, so many images, change the angles and so on, and magnify the data set. So it went something like that. Now, as for the images, can we upload them and make them training slides for the universe, essentially? Well, I don't know, because again, they will be patient information also. So that has to be, I guess, cleared up. I don't know. Mark, do you have anything to add to that? Sina Mark ang pinaka-nahirapan sa pagtingin ng slides.
Good afternoon, ma'am. Thank you for the question. I think an important issue that we have to consider before we upload the data set online is what's the university's policy about it. If there's nothing wrong, if there's not going to be any issue with the university regarding, because I think there's a patent pending for this particular technology, and the data set is integral integral and part of the development of the system. So if the university will say it's okay to be uploaded and to be shared open source, then there's no issue with it. Thank you, ma'am.
Thank you, Mark. So actually, I do not know what the policy is, but I'm actually raising the question because maybe if it's not applicable to this current data set because it's under a patent, I'm sure our pathologists are working on other slides that can be put together and made into a data set so that others can actually benefit from that. So thank you. The third paper is actually by Dr. Gaston. I was wondering why you didn't have a slide on the minority report of Tom Cruise doing all those gestures, because that's how I sort of envisioned it when you were talking about it. What I really like about this paper is it answers a need. You perfectly articulated why you needed to do this technological innovation. I can tell you that I have sat through a lot of tech conferences where sometimes the solution doesn't have a problem. Okay, because technology is shiny and new, people do all sorts of things, and the clinician in us would be staring and saying, okay, what are we going to do with that? So I love that it really came from a problem that you needed to solve. So I have several questions because you said the sensor, the camera actually detects hand gestures. Have you tried to sort of vary? So I was thinking, I think you were wearing a blue pair of gloves. So I was wondering if it was a flesh colored gloves or some other colored gloves. Would that be affected? My hands are small, so I don't know if a small hand and a big surgeon's hand would actually, interfere with the system.
Thank you, Doctora. Actually, the inspiration was Tony Stark. We thought about the problems of different glove colors. No, and actually the system has a setting that you can choose your glove color, so that if you wanted to use green glove, then that would be. But the standard setting is just for the usual white gloves, the product.
Would it change if there were blood on the gloves, for example, because we're in the middle of the surgery?
Yeah. So those were things we thought about as well, and things that we would be testing in the operating room setting.
Yeah, so it's very interesting. So already I was thinking about, like, if you put your device inside the OR, our ORs aren't that big. So even if you say I can do it from a distance, but then there might be intervening, I don't know, people walking by, or there might be gadgets or other OR appliances in the way. So I'm really hoping that we can test it out in the real environment. I also like that it's actually a low safety risk device, because I mean, if it doesn't work, you can just do it manually again, right? So it's very interesting to see what will come of it. So congratulations.
Thank you, Doctor.
So I guess I have no more comments, Ma'am Isa. Thank you po.
Maraming salamat, Iris, no, for elucidating and highlighting yung importance actually of clinicians, no, collaborating with the technocrats or the techies. Kasi ito yung the problem that we want to avoid, no, that we end up with devices that are not needed, no. Kaya I congratulate the UPC Ball, no, program plus the program where Alvin is involved. I forgot the name, no, that is still being funded. No? So I think that highlights the importance. This is an example of how we need to collaborate outside the university, no, so that cross colleges, no, and harness the expertise, no, and then come up with really solutions that are vetted by the stakeholders, those that are going to use the technology. So, any questions from the floor before we move to the next session? Wala. So I hope we all get inspired, no, on see how we create, innovate, no, the collaboration. Congratulations, so, Department of Orthopedics and Surgery for this. And then I'd like to say that NATS is heading the Discovery Hub. So, yung mga gusto mag-innovate through NATS, no? Yan. So we move to our next session. This time we'll hear from Dr. Mark Ang for the paper on dissection of type 1 neuronal splicing and implications for neurodegeneration in X-linked dystonia Parkinsonism. Mark?
So, good afternoon, everyone. So I'd like to thank the College of Medicine and the organizers of this year's Faculty Research Forum for the privilege of presenting this study in today's forum. This study was a collaborative work involving many individuals in different laboratories from several institutions and in various countries. The main author of the study is Simona Caponi, and the senior author is Dr. Mark Timmers, both from the German Cancer Consortium and the German Cancer Research Center. The laboratory of Dr. Mark Timmers is involved in investigations on medical epigenetics, including mRNA splicing and its effect on disease expression. So again, this is just to show that this study is really a collaborative one, and it involves many other institutions, including the Massachusetts General Hospital. So there's a collaborative center for X-linked dystonia Parkinsonism, which is based in Massachusetts General Hospital. And there's a local foundation here, the Sunshine Care Foundation, which is actually supporting all activities related to clinical care and research on XDP. So before I proceed, I'd like to present the summary slide. So if you get too deep, just go back to this slide. Essentially, this particular study tried to demonstrate whether or not the SVA insertion in the TAF1 gene affects the inclusion of the microexon 34 prime. So that's the main point of the study. And the result is that the study was, the current data was not able to gather enough information to say that indeed the SVA insertion, which is the pathologic question mark, the pathologic problem in XDP causes the exclusion of microexon 34. Okay. So now let's have a brief review of what XDP is. This is just going to be very brief. So X-linked dystonia Parkinsonism is also known as DYP3 by the dystonia classification, and it's also known as DUBAG in the local language. It's a rare adult onset progressive genetic neurological movement disorder, and it almost entirely affects men who can generally trace their roots in the Philippines, in particular in the Panay Islands. XDP was first reported in a conference in 1969 and was first reported in the literature in 1976. It's considered endemic in the island of Panay. The male to female ratio is 100:1. As of this year, 2022, there are at least 60 post-mortem cases already that the collaboration, the consortium has been able to accumulate. The mean age of onset is 39 years, and the usual initial presentation is focal dystonia. The dystonia spreads and generalizes within 4 years in about 80% of the cases, and then at 10 years onwards, there's a decrease in the dystonic symptoms, and the Parkinsonian symptoms emerge and become the predominant presentation. So the predominant picture is that of a severe dystonic movement involving the axial muscles, with predominant oromandibular involvement, such as jaw opening, tongue protrusion, neck torsion, trunk hyperextension. So these are the sketches and the pictures from the first described cases. And here we see the retroflexion of the head with wide opening of the jaw. So the individuals are often seen touching their heads because somehow that actually tricks the brain and halts the contractions. The picture on the left is is a person on the dystonic phase of the disease, while the picture on the far right is a patient on the Parkinsonian phase of the disease. However, in actuality, there's a spectrum. So it's a combined dystonia Parkinsonism. So these are additional pictures from the landmark articles. These are brothers with a disease. They have very low BMI due to poor nutritional intake due to the orofacial dyskinesia. There's also an increased basal metabolic rate due to the sustained muscle movements. Affected individuals also show blepharospasm. There can be abdominal contractions. And again, I hope you notice the prominent jaw opening. The patients, especially during the dystonic phases, they get really dependent on the activities of daily living. Some of the patients say that sustained muscle contractions are so painful. They're in so much pain, and the worst is that they can't even control their voice to shout or cry. So now we shift our attention to the neuropathology of this disease. So what do we know so far? So just a refresher, this is a diagrammatic cartoon of the basal ganglia. The blue region is the putamen. The green region is the caudate nucleus. The red region is the thalamus. The globus pallidus is medial too and is being covered by the putamen in this view. So this is a coronal section of the cerebrum showing the caudate nucleus, the nucleus accumbens, and the putamen. So this is the caudate and this is the putamen. So I hope you remember the expected contour of the caudate nucleus. It should be convex with respect to the lateral ventricle. So the largest detailed study of autopsy brain so far reported in literature was that in 2005, including Dr. Goto, Dr. Lee, and Dr. Edwin Munoz. They examined 13 brains, 7 of which were further studied using special techniques. This is a coronal section of the brain on one of the cases showing severe atrophy of the caudate nucleus. So here we see the concave profile with respect to the lateral ventricle. So aside from the atrophy of the caudate nucleus, there's also extreme or severe atrophy of the putamen. These are sections of the caudate and the putamen showing the normal, which is on the left, an XDP at the dystonic phase, and an XDP patient at the Parkinsonian phase. So these sections were stained with calcineurin. Calcineurin is a marker of medium spiny neurons, which are the predominant neurons in the striatum. So here we see in the dystonic phase and the Parkinsonian phase, there is necrosis and gliosis atrophy and gliosis of the caudate and the putamen. It starts out as a patchy, localized atrophy and gliosis, and then towards the Parkinsonian phase, the entire caudate nucleus, the entire putamen gets atrophy. Okay. So in order to really understand what this study was all about, I'd like to discuss very quickly the genetic basis of XDP. So subsequent studies of the family trees of affected individuals pointed to an X-linked recessive pattern of inheritance. So several genetic studies spanning the period from 1990 to present have continuously narrowed the positive genetic mutation. The mutations has been narrowed to a locus on the long arm of the X chromosome. So it's at the long arm of X chromosome 1.1. Again, this figure is from the 2015 article by Aloy Domingo, is also a UPCM alumnus. He's now in Boston in MGH working on XDP. So the disease locus contains 5 disease-specific single nucleotide changes, a 48 base pair deletion, a short interspersed nuclear element, a variable number of tandem repeats, and an ALU composite retrotransposon insertion, or for short SVA. So the normal Path1 gene, something gets inserted in an intron part of the gene. And that insertion is a retrotransposon. It contains, among others, a hexameric repeat. Very similar to what happens in Huntington's disease. So in a 2017 study by Dr. Chris Bragg, who is the current director of the Collaborative Center for X-linked Dystonia Parkinsonism, So XDP is actually being thought to be now as due to the hexameric repeat CCCTCP. And as there was a strong inverse correlation with the number of repeats and the age of onset of the disease, as well as TAF1 gene expression. So the longer the repeat, the more severe the disease, the earlier is the disease onset. Okay. So also in that paper, they were able to demonstrate, to gather evidence that the SB8 insertion causes intron retention. And this intron retention causes non-translation of the mRNA to protein, causing a drop in the amount of TAF1 in the cells. So there's actually a lot going on in the genetics research group. So this particular paper is all about TAF1, which is a Tata binding protein associated factor. So it's a protein that is the largest component of the basal transcription factor TAF2T, which is an important factor required for the initiation of RNA polymerase II. So remember, RNA polymerase II is involved in transcribing DNA to RNA, to mRNA and other small RNAs. Okay, so let's go back to the main point of the study. So in this study, they tried to demonstrate whether or not the insertion, the SVA, causes non-inclusion of the microexon 34 prime. So the TAF1 protein has many isoforms, and in the brain, there's a specific isoform called NTAF1, although it's not official yet. And the only difference with the canonical form of TAF1 is that in NTAF, the microexon 34 prime is included, so it's spliced in. So there's a group in the collaboration that's who thinks that maybe the SVA is causing exclusion of the microexon 34 prime, and because of that exclusion, it's causing downregulation of expression of TAF1 in the neurons, and that's driving the cells to die. So this particular study performed two mini studies. The first study is on cell lines. They tried to determine whether or not the insertion of SVA causes downregulation or non-expression of the TAF1 34 prime isoform of TAF1. And the second part is that they analyzed 7 XDP postmortem brain tissue and 4 control brains, and they tried to determine the amount or the levels of the two isoforms, TAF1 with microexon 34 prime and the canonical form of TAF1. So the results of their study actually showed that there's no difference. Okay, so in this first panel, this is from the cell line assay, and it shows that actually those mini genes, so these were inserted or transfected into the cell lines. Cells with the mini gene and cells with the mini gene and the SVA both express the canonical form of TAF1. If we include a factor, a splicing factor, SRRM4, both the mini gene without the SVA and the mini gene with the SVA will also express or also form the TAF1 34 microexon. So in other words, this picture just says that there's no difference whether or not there's an SVA. The microexon 34 prime will still be incorporated into the final mRNA molecule. And this is the last image. So this is, they tried again to measure the amount of TAF1 34 microexon isoform in the brain and the amount of canonical TAF1 in the brain, comparing controls and XDP, and they were able to see actually a lot of variability. So in some areas, there appears to be a loss of expression. So for example, in this particular sample, 17.06 PFC and 17.01 AP. So AP means anterior putamen. So there's actually loss of the NTAF1 or the TAF1 34 prime isoform of TAF1, while the canonical form is still being expressed. However, this is not seen across all areas of the brain. So there's variability. And this, we think, is the reason why we were not able to demonstrate a significant difference between expression of this particular specific isoform of TAF1 in the brain. A nanopore-based sequencing was performed on the brain samples just to determine what types of isoforms are there in the brain tissue. And again, the study compared the types of isoforms found in control brains and the types of isoforms found in the XDP. And as you can see here, there's really not much difference. So overall, the findings of this particular study do not provide support to say that the SVA affects the splicing of the microexon 34 into the NTAF mRNA. So it's a negative study, but in this particular sense, in this particular case, it's very important because really we still don't know what's driving, what's causing the cells to die. And the more explanations we weed out, then whatever's left must be the explanation. So with that, I'd like to thank you for your attention.
Thank you, Mark, for presenting your collaborative work. Now let's hear from the Department of Psychiatry. This paper is headed by Dr. Cynthia Lanes, to be presented by Dr. Jeffrey Kiring on psychological interventions used by mental health professionals for inpatients of tertiary hospitals referred for psychosocial problems.
Thank you, ma'am. Good afternoon, everyone. It is my honor and privilege to be presenting this on behalf of Dr. Cynthia Lanes, our team head, who unfortunately cannot make it today because she is abroad. And we also want to mention that we have other faculty members from the department who were part of this project, but this is really a collaboration between different institutions. So this is entitled Psychosocial Interventions Used by Mental Health Professionals for Inpatients of Tertiary Hospitals Referred for Psychosocial Problems. So there have been more evidence recently on the psychosocial factors influencing health outcomes, supporting, in fact, or lending credence to the biopsychosocial framework that we really advocate and push for today. In fact, a more recent iteration of this would be the emphasis on the biopsychosocial spiritual framework that is being promoted by the Philippine Council for Mental Health. So there have been emerging evidence that psychosocial factors impact prognosis of other medical and surgical conditions and response to medical interventions. And so we wanted to look into this. In fact, we would like to first clarify that the definition that we used here for the psychosocial interventions would be the one from the Institute of Medicine that says, this capitalized on psychological or social actions to produce change in the psychological, social, biological, and or functional outcomes. So simply put, it will involve any kind of intervention, both that excludes pharmacological intervention. So outside of the pharmacological intervention, all of them will probably count in this discussion. Scientific literature mentions a wide range of psychosocial interventions that includes psychoeducation, individual, couple, and group psychotherapies, psychosocial rehabilitation, as well as other initiatives such as supported employment and case management. Although there are varying degrees of evidence for the different interventions, clinical practice guidelines, both local and international, have included psychosocial interventions as options in the management of patients. And patients recognize the effectiveness of psychosocial interventions. And in cases where evidence, in fact, points to similar efficacy, we find that there is a preference for the former. So furthermore, the utility of psychosocial interventions cannot be overemphasized for cases where medications are contraindicated, their side effects not tolerated, and they are inaccessible or unaffordable. So we want to expand our treatment options and the evidence for these interventions, especially for the greater need that we see now in our society. And so this study looked into this. So the following objectives were the ones we tried to address in this study. So first, to describe the demographic and clinical profile of the inpatients in non-psychiatry units of tertiary hospitals referred for psychological problems to mental health care providers. Second, to describe using ICD-10 codes the prevalence of psychiatric disorders among inpatients in non-psychiatry units of tertiary hospitals referred for psychological problems. Third, to describe the psychosocial treatment interventions. And then to determine the most common psychological problems perceived by health professionals among patients who needed psychosocial interventions. We also wanted to describe outcomes of the management of the mental health and behavioral problems among inpatients admitted to non-psychiatry units. We also wanted to look specifically at the issue of gender and maybe the differences that we might see there. So the mental health providers we wanted to look into the gender disaggregated data. And we also wanted to create a guideline for the management of mental health problems among patients admitted to non-psychiatry units in inpatient units in tertiary hospitals. And lastly, to develop a list of community resources that may be utilized for aftercare by patients discharged from these hospitals. So quite a lot. This project was generously funded by the PCHRD, and so we also wanted to have several outputs here, but we'll be presenting here a part of the results. So the conceptual framework that we followed would be the following. So we look at the psychosocial interventions being influenced by patient-related factors such as demographic profile as well as clinical profile. You also look into the provider-related factors, including their demographic profile as well as their service provision factors such as training, and then hospital-related factors such as hospital policies and everything that would pertain to service provision inside the hospital. So our methodology was to use a mixed method design using both qualitative and quantitative methods using the convergence model of triangulation. So our data sources were the following. First, a cross-sectional review of charts of patients diagnosed with mental health and behavioral disorders in selected tertiary hospitals. We also did a survey of mental health service providers from these institutions. And then we did key informant interviews and focus group discussions among mental health providers. So this is a summary of the different steps that we followed, starting with the technical and ethical approval in the different hospitals. And then we basically tried to compare and contrast the findings and interpreted them together. So what I'll be presenting is more of an integration. So these were the hospitals that were involved in the study. And we have a mix of different kinds of hospitals, private, public, and big, medium, and small hospitals. So we also had to employ statistical methods, and we asked help from 2 statisticians. For the chart review specifically, we used the all reported confidence intervals were constructed using non-parametric bootstrapping, and reported p-values were obtained using the same procedure. For the survey, the average rank was determined for most responses, and the association was measured. Results were generated through EpiInfo, SPS 7, SPSS 20, and Stata 13. And for our FGD and KII, we used a manual approach in generating and analyzing the results, and these were validated by the different authors. So these were the sources of our data, and this is the distribution of medical records and survey respondents from the different hospitals. Our participants were from the following. So figure 1 shows us here a number of inpatients referred for psychosocial interventions from the different hospitals. And the number of figure 2 shows the number of mental health providers in the 7 hospitals who were interviewed. So for the profile of patients from the medical records, so we had mostly adult patients comprising 92% of the respondents, and then almost an equal
number of male and female, as well as married and single respondents. And unfortunately, we don't have data for some of the other uh, areas or parameters, and so there were incomplete data there. And but we, especially for the employment status, but for the insurance, we also noted this to kind of just to look at into the socioeconomic status. And then we also looked at the family history of mental illness and comorbidities. And so these were the top results for those who had comorbidities. For the profile of our KAI and FGD respondents, we have the following. Most of our respondents were in fact psychiatrists, especially for the KAI, we had 3 psychologists there. And for the FGD, we had mostly psych consultants and the residents also, but we also had a few other doctors from other specialties as well as nurses, which comprise most of the other allied medical professions, no, that we try to work with. So these are some of the results that we gathered. So reasons for referral to psychiatry for inpatients with psychosocial problems were the following. Mostly the top 2 across all different data sets were depression and anxiety. And there were some differences in some of the numbers, but mostly these were the top responses. And then strategies in addressing psychosocial problems among inpatients for the charts were the following. Basically, we saw that psychosocial interventions was used in most of the cases, and around 52% of that employed a combination treatment, meaning medications and psychosocial interventions. In terms of the strategies in addressing psychosocial problems among inpatients, in the other data sets, we also saw a similar trend. So even in the KAI and the FGD, from the provider's perspective, it was also a combination treatment that they used. When we look at the differences in results for public and private hospitals, there wasn't much in terms of this area. And here are the specific types of psychosocial interventions that we saw. And the top responses here would be psychoeducation and supportive psychotherapy in almost all of the different data sets. So some of the ones that were mentioned also among the top responses were family therapy, behavioral therapy, relaxation techniques, or CBT, and mindfulness and spiritual counseling. But the top responses really were psychoeducation and supportive psychotherapy. We also looked at the diagnosis of our patients from the chart, and the top responses were, the top conditions were mood disorders as well as organic mental disorders or other conditions that were seen in the patient that was part of the comorbidity. And so the distribution of length of hospital stay of patients, disaggregated by patients assigned sex, are as follows. So we looked at the different data, and around 2 weeks to less than a month was the most common response that we got here. So in terms of the sex and the provision of care, we tried to look into some data, and in the chart review, it revealed that our patients were attended by a team of mostly mixed gender composition. So both men, male and female. And there was no significant association between the patients assigned sex and the gender composition of the mental health professionals. The data from the survey on the reasons for admission and referral for psychosocial problems disaggregated by sex showed no sufficient evidence that sex of the respondent or mental health provider was associated with the reason for admission and referral. And there was no sufficient evidence to show that the types of psychiatric interventions given were different, except for family therapy, and which we were curious about, and then we wanted to explore. So for the intervention hospital type, a higher proportion of patients admitted to public hospitals received psychosocial interventions only than those admitted to private hospitals. And the higher proportion of patients admitted to private hospitals received pharmacotherapy only than those admitted to public hospitals. So here are the preferred type of in-hospital management of psychosocial problems, disaggregated by hospital type. So mostly, really, it was a combination treatment that had the highest response for this area. So the factors that influence choice of psychosocial interventions were explored in the survey among mental health professionals. Basically, this is a mix of doctors, nurses, and other allied medical health professionals. And so they've identified that psychological status and the medical status were the top choices that influenced their choice of intervention. Evidence was not sufficient to show that there was a difference between the response of male and female providers. And the findings from the survey were validated by the responses from the KAIs and FGD. So that was consistent. So we just wanted to show here what the other factors that were mentioned or considered. And so we emphasize again that the top responses were the psychological status and the medical status. So as for the type of intervention and outcome, a higher proportion of those who received combined or combination treatment were discharged with follow-up instructions compared to those who received psychosocial interventions only or pharmacotherapy only. On the other hand, a higher proportion of those who received pharmacotherapy only were discharged without follow-up instructions compared to those who received psychosocial interventions only and combination therapy. So the use of all types of psychosocial interventions were significantly related to patient getting instructions to follow up. Here's a distribution of the outcomes in patient mental health service provision disaggregated by gender, which we found not to really be significant. And this is the percentage of patients who return for follow-up. So as mentioned earlier. So we'd like to explore in greater detail, though, the reasons for this. And what we looked at were the responses of our mental health professionals in the service providers, I mean, in the survey. And so the top reasons were the following. And the perceived factors for failure to follow up, according to the survey also, was financial consideration. And due to the limitations in the access of the medical charge, however, and the distance from home and financial consideration were also perceived top reasons for failure to follow up in KAIs and FGDs. So we wanted to explore these since we said that we don't have a lot of data here. So part of our discussion, we recognize that there's really a paucity of data, and we also were limited by COVID-19, and we also know that the charts there were some data that were not available there, and probably this is also really just an underestimation of the exact numbers there, but at least this is a good start. In this study, combination treatment with both pharmacotherapy and the psychotherapy was the most common strategy in rendering psychiatric services. And key informants and FGD participants attributed this to its greater effectivity compared to single modality intervention. So as I mentioned earlier that there's still positive studies on combination treatment for other psychiatric conditions. There is enough evidence for its utility on depression and anxieties, especially for severe cases. So we wanted to look into that. Most international recognized treatment guidelines include combination treatment, either in sequential pattern or right at the start of treatment. And we try to understand what were the reasons for this, and some of our respondents in FGD and the KAI mentioned that they looked at the effectivity of the treatment that actually drove them to also decide whether to use combination. And for the patient-related factors, this played a big role in determining the kind of intervention. So in a study, in fact, that's also in the previous, this reflected also, in fact, what other studies of Dr. Trinidad Colhencio et al. In PGH also got before. No? So although I don't have time to elaborate on it, but we wanted to look into the profile of those who received the interventions. But what we just like to highlight here now is that the most common reasons for referral to mental health professionals were the following conditions that were consistent with previous findings, as well as the length of hospital stay for about 40% of patients study was 2 weeks to 1 month and more than a month for about 10% of the patients, which was also consistent with some of the findings. So let me just go to the other parts here. So in the survey, healthcare providers were identified as mostly the middle-aged female and were either medical doctors, and there were very few psychologists in the hospitals and other medical professionals. And so most of them were really the psychiatrists. So let me skip the other parts here. Let me go to the output that we've created, because I think this was really going to be something that we wanted to share with the hospitals, a list of mental health services for psychosocial interventions, as well as treatment recommendations for psychosocial interventions for referred inpatients. And so this is the first version of it has been out already, and we wanted to work on it. There have been several limitations to this study, especially employing the mixed methods and specifically looking at mostly just the perspective of the mental health or the care provider. And so we want to explore more the perspective of the patients as well as hospital administrators. And but the conclusion for this is the following, and then our recommendations basically is to look into the policy and the treatment opportunities. We want to look at the research and as well as training of other care providers in the hospital, because there aren't too many psychiatrists, as we all know. And we also want to look into the following in terms of providing psychosocial support in the hospital. So improvement of identification, measurement, and understanding of psychosocial problems in the hospital community settings, in provision of care in the community as well, and link between the hospital. So basically for follow-up purposes. And so also we wanted to integrate most of the mental health promotion strategies into other things that we do in the hospital. So anyway, there are a lot here, but we would be willing to share a lot more in the coming or the other in the other venues, and we're actually writing our paper now, so we could disseminate the data that we have. So thank you very much.
Thank you, Jeffrey, for your presentation. Now, let me call on the Chair of the Department of Neurosciences, Dr. Calista Joquino, to react on the two papers.
So first, let me thank the leader for inviting me to react. I was not sure how much I could contribute to this forum, but let me try to give you some reactions to the two papers that were presented. So for Mark's paper, he actually gave us an overview about the evolution of knowledge about XDP. In my mind, XDP is X-linked dystonia of Panay, but the real term is X-linked dystonia Parkinsonism, or Mark said Lubang. Yeah? And he showed you that it's a neurodegenerative genetic movement disorder afflicting Filipinos of Ilonggo descent. And he showed you in one of the slides the drawings made by Dr. Viterbo about his patients who had lubang. So those were early studies he did together with Dr. Lilian Lee. And the focus was describing the demographic and clinical characteristics of the disease. Mark also showed you the evolution. Remember, starting with dystonia, then a mix, and then Parkinsonism. And even further evolving such that the patients are really unable to care for themselves, totally dependent on others for care. And then he showed us also the neuropathologic studies, which came after the description of the clinical manifestations. And just to refresh your memories, he actually showed us atrophy, right, in the caudate. And, atrophy means neuronal loss in those structures, the caudate and putamen, and also pachygliosis in other parts of the brain, the striatum and the substantia nigra. Following the neuropathologic studies, when genetic studies came involved, then they discovered, the early genetic studies localized the disease to the proximal long arm of the X chromosome, and specifically in the XQ13.1. And as he showed, what is known today is it has something to do with a hexameric repeat in the intron of the TAF1 gene. Medyo mahirap na parang sa akin na intindihin yun. But he showed you that they were looking at whether the alternative splicing of the gene could be the explanation for the disease. And it turns out na parang na-debunk yung theory, yung hypothesis. So actually the race is still to find out what really causes the disease. And actually the study raised more questions. I guess that's the way it is in research, no? It raises more questions. So one of the questions is there a genetic explanation for the phases of the disease? He showed us that there is a neuropathologic explanation, but is there a genetic explanation for them? Next is, are there implications for treatment in the future? And for me, as a toxicologist, my concern is there an epigenetic factor driving this genetic expression? And so Mark, maybe you'll tell us later, where do we go from here? Now, for Dr. Killing's presentation, I just want you to give you some kind of perspective about mental health. No? You all know that it is one of the priorities for healthcare in our country. In fact, the RA 11036 was enacted 5 years ago. And it was meant to establish a national mental health policy to enhance delivery of mental health services and to protect the rights of people with neurologic, psychologic disorders. And so, parang yung strategies nila nakatukoy sa strengthening leadership and governance, developing more programs, enhancing mental health care system, protecting rights, strengthening information systems, etc., etc. Now, following the enactment of that law, then we do have now the Philippine Council for Mental Health. And the council directs a lot of activities with regards to mental health, including research. In a parallel development, the mental health research priorities were determined through a project which was conducted by the World Association of Psychosocial Rehabilitation. It was taken after the National Unified Health Research Agenda, where mental health was one of the important topics that they raised. And so in that document by the World Association of Psychosocial Rehabilitation, they said that there are 3 main outcomes which would be desired from mental health research in the country. And those outcomes were improved national mental health information systems. Second is improved national mental health governance, which includes integration of mental health in primary care, having community-based mental health facilities, and increased investment in mental health. And even digital technologies were identified as enhancing mental health care. And the third outcome was accessible, affordable, responsive, and rights-based mental health services and care. And so for me, this research on treatment recommendations for psychosocial interventions is one such topic addressing the knowledge gap of the third outcome. And the paper is really a good start. We are going to improve mental health services. This is for psychiatry liaison, for mga inpatients
with psychosocial problems, not necessarily psychiatric disorder. So this would be a good place to start to improve services for this kind of population. What I particularly appreciate in the recommendations, the particularly was the team approach in holistic care for patients with psychosocial problems. And also there was a recommendation for the use of rating scales. And I think that will contribute very well for the uniformity of assessment of these patients. So that's it. I have no questions for you, but the others might.
Thank you very much, Teresa, for the insightful reactions, not and sorry, important reactions. And I'd like to pose the question that Teresa raised to Mark. Any insights on how we move forward based on the finding? Because I think it's important, no, to study the molecular basis, no, for the disease, and then how we can use that findings, no, from. Kasi ngayon, now we are able to go beyond just clinical. We are able to study the genes and
Thank you, ma'am. Thank you po, Dr. Rajo, for that very good reaction and for asking important questions po. To reply to the questions, ma'am. So the first question is, are there genetic explanations for the evolution of the presentation? Right now, wala pa pong specific na parang coherent theory as far as I know. But the progression of symptoms is correlated or is associated with the differential susceptibility of the different cells in the caudate and the striatum. For some reason, it appears that medium spiny neurons in the striosomes are the ones that first to undergo degeneration, and this degeneration later on spreads to involve the other components of the striatum, and that's when the Parkinsonian presentation of the disease is manifested. Whether or not there's some other cellular and molecular pathways that are involved in the differential susceptibility of the neurons at different stages in a patient's life, we still do not yet. Investigations are still ongoing. So there are several leads, shall I say, leads that are being followed by the different investigators involved in the collaboration. One is the hexameric repeat. So the favorite theory of Dr. Chris Bragg is that there's actually a gain of function effect with the insertion of the hexameric repeat, and there's also a loss of function to the TAF1. So the loss of function aspect is actually the mother theory, where the alternative splicing, which was investigated in the paper that I presented, falls in. The other gain of function theory is that the hexameric repeat actually codes for a protein that becomes toxic to the neurons, and that could potentially explain why in patients with longer repeats, the expression of this protein actually is more pronounced. There's more aggregation, and that could contribute to the increased or accelerated death of these neurons. However, I think studies are still ongoing to find that protein, kasi right now parang hindi pa rin po sigurado. And there's also another theory proposed by Dr. Jeff Hua and Dr. Ann Blood, wherein they're implicating neurotoxicities, something neurodevelopmental, and they're saying that increased stimulation in those areas of the brain actually causes a neurotoxic effect on an already susceptible cell because of the mutation. However, I think they were investigating this through diffusion tractography, MRI. I think they're trying. However, in the latest data set that they were able to publish, I think again na debunk din ma'am yung theory. So parang it's exciting kasi there are several theories, some complementary, some competing, and some some theories are being weeded out, and it's exciting because the list of possible explanations are getting smaller and smaller. And regarding whether there are druggable targets, I think the group of Dr. Bragg is also looking into this, and they're thinking that if the real problem here is the gain of function effect of the hexameric repeats, there's a mutant protein that's causing toxicity, then maybe they can insert an oligo-based drug that can bind and silence the expression of this mutant protein, ma'am. So far, parang yun pa lang po yung nakuha kong update. Thank you po.
Thank you, Mark, and I hope you continue the collaboration. Actually, I see this also as an opportunity for our MD PhD students, medical students. We'd like to mentor them as well, no? Involve them in the program. So, yeah, X-linked dystonia, there's a lot of interest. No? And then for Jeffrey, yeah. Okay, also probably same question. And how do you intend to move forward, no, the findings, no? So what are the strategies with the department? Because again, this is a very good collaboration this time in the country, no, among the providers of mental health, since it's an important priority in healthcare, no, as pointed out by Teresa.
Thank you very much, ma'am. And thank you very much, Dr. Tino, for the comments earlier. In fact, this is really one of the researches that was born out of the National Mental Health Research Agenda, because we wanted to provide evidence nga po to the knowledge gap that we have. And this is something that we are also proposing to the Philippine Psychiatric Association and the different institutions, as well as the other societies that are working towards mental health. Because in our study, we did recognize that there are many psychosocial issues or problems in the hospital, and we don't have a lot of psychiatrists in the hospital. And some of them, in fact, do not need to be seen by the psychiatrist anyway. And so we want to come up with programs that will be able to address already some of the needs early on, and put up a system that will be able to address this concern. So in terms of moving forward, ma'am, we want to discuss this even more. It was mentioned earlier that this kind of falls under the consultation liaison program, ma'am, that when the other doctors will refer to psychiatry in a formal way. And so, yes, we want to strengthen that also, that partnership, as well as maybe come up with these kinds of units in other hospitals who still do not have consultation liaison programs. But even for other hospitals, we envision that mental health will really be part of the training of the doctors, of the staff, and how to relate to patients, and as well as cascade the different programs. So, ma'am, there's a lot of work to be done. And we also understand that this is just but a small part of the many other things that we need to do. So, but at least thank you po for the opportunity to share what we have here. And it's also an encouragement to all of us to get into the mental health research, because as far as we've seen po, there have been a lot of other doctors and allied medical professionals who are doing research in this area. And so it's not limited to the psychiatrists anymore. Thank you po.
Thank you, Jeffrey. Yeah, again, highlighting collaboration, no, and maybe challenge to Department of Psychiatry. Yes, Tina, and then Mike.
For the mental health study, I just wanted to ask I'm interested to know what was behind the gender disaggregated data. What hypothesis did you have? And then second, if you also included COVID patients, because I understand this was carried out during the COVID times. Because well, I'm a dermatologist, but I've had patients who after COVID consulted for dermatitis, and during the consultation they would say they were because some of them were actually
confined in COVID wards in referral hospitals, and some of them would have suicidal ideation during their confinement.
Thank you very much for the question. We did not anymore state in our presentation, but most of the charts, I mean po, that we looked at were from the period of 2014 to 2019. So that's pre-COVID. But the focus group discussion, the survey, as well as the FGD po, were done already during the COVID period already. And so many of the insights of the care providers, so we didn't get any from the patients, unfortunately. So, but from the mental health providers as well as the other health providers, non-psychiatrists, there were perspectives related to COVID. And so we did not present it anymore, but we also had some data on the changes that occurred in terms of practice because of COVID. So going online, looking at other therapies that were applicable for COVID. But for the patient, ma'am, ano po, this was the pre-pandemic picture. So yeah, so yun po yung I think for the first part, ma'am. So yung sa gender po, yung gender, part of what we wanted to look into and explore was the fact that there might be some differences in or the comfort of some patients with regards to having a therapist or a provider of the opposite gender, or if there will be gender issues there. Unfortunately, we also didn't have a lot of data, so because it was not really reflected on the chart. So again, it was the perspective of the providers. So if there were some difficulties with maybe helping a patient of the opposite sex or gender, no? So yun, ma'am. So I think it was more of an exploratory. And then we looked at also the description of if there were cases that some patients requested for a particular kind of therapist, like dahil po babae siya, I want a female therapist as well, or something like that, because of maybe some issues related to especially sexual violence. But I think, ma'am, that was part of the reason and something to explore moving forward also.
Thank you. DC Mike, please.
Actually, I attended this and I saw your presentation and interested in the psychological aspect, because in 2016, we developed the Uplift. And right now, Dr. Mantari, our OSA director, has upgraded it. And it is a multi-professional, interprofessional intervention where our students can look for a counselor. It's like a Grab. No, it's technology-based. It allows us to maintain anonymity, provide privacy, and at the same time, allow better access. So I'd like to ask whether you'll be interested in looking at our data and see how the interventions are effectively accomplishing what that Uplift app is supposed to achieve. And it is available in Google Play and also in a month in iOS or Apple Store. So this is an invitation, and I hope you can study our students' population, and then with your network of psychiatrists, be able to deploy it all around the country. We did it for free without funding as a student, and collaboration between the engineering college and the UP College of Medicine.
Thank you very much for the invitation, Dr. T. And definitely this is something that we would want to look into. And I know there are also other initiatives related to this, and I'll definitely inform our team and as well as the entire Department of Psychiatry and Behavioral Medicine who definitely will be interested to see what we can do in terms of going into this area and giving more help to our students. Thank you.
Thank you for the reaction, the questions, and the responses. Congratulations to the Department of Pathology and Psychiatry. Now we move to the next session, which involves clinical molecular studies. So we start off with biomarkers in combination with pediatric organ dysfunction scores for prognostication of pediatric sepsis and septic shock. A pilot study to be presented by Dr. Emilio Villanueva III from the Department of Pathology.
So, good afternoon. On behalf of our primary investigator, Dr. Luis Joshua, and our co-investigators, Dr. Tan and Dr. Wu, I will be presenting our research collaboration between the Departments of Pediatrics, Pathology, Laboratories, and Medicine. So, sepsis is a preventable global health priority as declared by the WHO and World Health Assembly in 2017. Based on the analysis of the 2017 Global Burden of Diseases study, 41.5%, 10%, and 4.1% of the incident sepsis cases occurred in children younger than 5 years, older children, and adolescents, respectively. Sepsis-related deaths accounted for 19.7% of total deaths in 2017. Pediatric sepsis and septic shock entail significant morbidity and mortality. In a third world country like the Philippines, where resources are lacking and often limited, it is important to identify and stratify patients who are at higher risk for further deterioration, which more intensive care will be needed. This study determined the prognostic value, or at least tried to see if it would be feasible to do a full study of combining biomarkers and organ dysfunction scores in identifying these patients. So this was our research question with the population of pediatric patients with sepsis and or septic shock admitted in the hospital. We follow this cohort of sepsis and or septic shock patients to evaluate a combination of different biomarkers and scoring systems as predictors of in-hospital mortality. Review of literature shows that elevated absolute neutrophil count, neutrophil lymphocyte ratio, procalcitonin, interleukin-6, and lactate are associated with disease severity and poorer prognosis. Since these biochemical markers may also be affected by other disease states, it is prudent to adjust for potential confounders. Other possible causes of mortality among sepsis patients would be investigated as effect measure modifiers. So for this study, we followed the 2005 IPSCC definition and criteria for sepsis and septic shock, and the scoring systems used were as validated by the following, which I cannot pronounce. The biomarkers were measured by standard laboratory methods as offered by the Department of Laboratory. So this is the general objective of our study and the specific objectives. So we utilized a prospective cohort study design following the cohort of pediatric patients admitted at the Philippine General Hospital, newly diagnosed with sepsis or septic shock. This study was approved by the UPCM rep. So the following were the inclusion and exclusion criteria that we have used. And we have performed a consecutive sampling method wherein we recruit patients as they come and referred to the study. So for this pilot study, we initially targeted 45 participants, 30 of which from the computed sample size, and an additional 15 as enough buffer for possible dropouts. However, there were only 38 patients referred to the study during the study period, and 7 patients were excluded due to various reasons. So pediatric patients with sepsis or septic shock admitted in the emergency room, ward, or intensive care unit are referred by their attending physicians to the study. The eligibility criteria are screened and consent was sought from legally authorized representatives. Interleukin-6, bilirubin, and lactate determination were added to the routine institutional sepsis workup, which includes CBC, C-reactive protein, procalcitonin, site-specific cultures, arterial blood gases, and creatinine.
By routine practice, samples were taken upon assessment of sepsis or septic shock and on day 3 of antimicrobial therapy to monitor the treatment response. All included patients in the study were managed based on the standard of care of pediatric sepsis and septic shock. Participants were grouped to either mortality or survivor groups, and the time from admission to mortality or discharge were also collected. So we performed descriptive statistics and classical tests of hypotheses for their non-parametric counterparts in order to describe the characteristics of the participants of the study. And the main bulk of the statistical analysis was devoted in the selection of predictors of in-hospital mortality. So a receiver operating characteristic curve analysis with cut-off identification by Yoden index was initially performed in order to dichotomize the different biomarkers and scoring systems. So we followed a similar adult study. So these dichotomized biomarkers and scoring system were analyzed by Cox proportional hazards regression with all cause in hospital mortality as the event and time to mortality or right sensor time to discharge or transfer as a time data. An initial univariable screening was performed with a cutoff of p-value of 0.15. To prevent multicollinearity, only the one with the lowest p-value among the day 0, day 3, and percent decrease per biomarker and scoring system was included in the multivariable analysis. Since we aim to evaluate the combination of these biomarkers, only those with complete set of biomarkers and scoring system results were included in the multivariable analysis, and missing values were not replaced nor imputed. We also identified the significant predictors of in-hospital mortality by backward selection. So after screening for the predictors, we have also screened and confirmed the effect measure modifiers as well as the confounders in the relationship between the biomarkers and the scoring system with in-hospital mortality. And finally, all predictors, effect measure modifiers, and confounders that were deemed significant by the earlier analysis mentioned were modeled with multivariable logistic regression in order to determine the probability of all-cause mortality and the coefficient of determination of the logistic model, as well as the area under the curve, were determined in order to assess the prognostic accuracy and the variation in mortality explained by the model. So after the extensive statistical analysis and modeling described earlier, we have found out that high day 0 interleukin-6, high day 3 neutrophil lymphocyte ratio, high day 3 procalcitonin, and a low percent decrease in the absolute neutrophil count, as well as a high day 3 PELOD2, taken together as combination while adjusting for the confounding variables, were significant predictors of in-hospital mortality. This model has a very good predicting ability, and it explains about 40% of the variation in mortality among pediatric sepsis and septic shock patients. So sepsis is the result of an infection that has triggered a systemic inflammatory response, leading to relative increase in neutrophils and decrease in lymphocytes. This complex balance between the innate and the adaptive immunity is reflected in the absolute neutrophil count and the neutrophil lymphocyte ratio. Persistent infection results in immunosuppression, that is lymphopenia, and inflammation with neutrophilia, causing organ dysfunction. Procalcitonin is generally undetectable in healthy individuals. However, during sepsis, extrathyroidal production causes plasma levels to rise within 4 hours up to as high as 100 nanograms per ml. The actual level is dependent on the type and extent of the inflammatory response. And the high day 3 NLR, high day 3 procalcitonin, and low percent decrease in the absolute neutrophil count reflects the inadequate response in treatment. For the interleukin-6 levels may peak in 2 to 3 hours during infection, but rapidly declines to undetectable levels regardless of the evolution of the primary infection. This explains why the day 0 interleukin-6 was a better predictor than the day 3 or percent decrease in the interleukin-6. Pelod 2 is designed to be used on the day of admission or at the day of the assessment of the patient. However, in our study, it was day 3 that has been more useful than the day 0. This may reflect that the 3 days is not enough to repair or resolve the organ damage or dysfunction that the patient has. While other studies show that lactate and PSOFA alone is a good predictor of mortality, and with the predicting ability was even increased when these two are combined, these two markers were eliminated in our variable selection. Our finding may reflect the findings of other studies that the combined lactate and PSOFA is a good predictor of mortality. And both of these variables were dropped off in our modeling since they are both included in the PELOD 2. PELOD 2 may have a better scoring distribution than PSOFA in terms of the different levels on the scoring system. Hence, the PELOD 2 was retained in the model rather than PSOFA. Our findings adds evidence to the potential utility of evaluating multiple biomarkers and taking into consideration their temporal changes in sepsis and septic shock, since they are dynamic processes. This is a dynamic process that change in response to treatment. However, given that this is just a pilot study, there may be some changes in this model when a full study is undertaken. So some different combination may appear as significant rather than what we have seen in our pilot study. But at least we showed that the combination or doing this study is feasible. So thank you for your kind attention.
Thank you, Dr. Villanueva. We now move to the next paper, skin prick test and enzyme link immunosorbent assays among allergic patients using local pollen extracts, represented by Dr. Mary Ann Castor from the Department of Pediatrics. Good afternoon, and thank you to Rido for allowing us to present our study. This study is a collaboration between the Department of Biochemistry and Molecular Biology and the Division of Allergy and Immunology of the Departments of Medicine and Pediatrics. So these are our disclosures. Allergic respiratory diseases are not life-threatening, but they're known to affect the quality of life of these patients, and hence early diagnosis and control of symptoms is important. Allergic rhinitis affects 20% of the population, and asthma affects 8.7% of the population. This is based on the National Nutrition Health Survey of the Philippines. Now, to diagnose allergic rhinitis, you need to rely on the clinical history and physical examination, and the diagnostic tools which help confirm the presence of IgE antibodies and also identify the allergic triggers for this patient. Now, for these patients, you can either do an allergy skin prick test or a specific IgE test to confirm the presence of IgE antibodies. And this only means that the patient is sensitized. So we are not really confirming that the patient has clinical allergy. Okay. In a study, this is a retrospective study of the skin test done at the allergy clinic of UPTGH. You can see that indoor allergens are the most common sensitizers. However, you can see that outdoor pollen beings are also significant sensitizers. And these are some grasses, weeds, and trees. And what is significant here is that the Philippines, being a tropical country, has a wide variety of plant flora that can possibly trigger pollen allergy. And in terms of pollen extracts, it is only our center that produces this pollen extract. While in indoor allergens are also produced by other countries. So our study objective is to determine the sensitization profile of our local pollen extracts among patients with respiratory allergies through skin prick test and specific IgE ELISA. Okay. So this is a part of a bigger study, and this is this cross-sectional descriptive study. So for this study, pollen grains were collected and processed into allergen extract. Sorry, the slide showed did not work now. And the study participants were subjected to skin prick test with this allergen extract. And for patients who were positive to the skin prick test, blood was extracted, 5 ml blood was extracted, and the sera were used for the ELISA, where they were subjected to the same pollen extract. For the results of the study, there were 129 patients who had positive results out of 165 patients who underwent skin prick test. And all these patients who had positive results with skin prick test underwent specific IgE ELISA. So, and from this, 55% or 71 patients had positive results. So these two groups are not entirely different, no? Those who had a specific IgE ELISA were those who had positive skin prick test results. So you can see here that the median age for skin prick test was 27. For specific IgE, it's 26. And there were more females in this study. Most of the patients had allergic rhinitis, and some had allergic rhinitis and asthma. Very few patients had asthma alone. And looking at the proportion of positive results per pollen extract, you can see here that for the skin prick test, weeds had the most, were most sensitizing. So it ranged from 51.9 to 58.1%. And the weeds here are pigweed, macaria, and wild daisy. So for the specific IgE ELISA, the highest sensitization rate was coconut, followed by pigweed, Johnson grass, and rice. Among patients who had positive results to the specific IgE ELISA, you can see that per pollen extract, the optical densities were very variable. And the highest optical density actually came from a patient who tested positive for coconut. The red line there represents the cut-off of the optical density, above which we have detectable serum IgE results. And we use this cut-off for inclusion of patients in the next objective of the study. So this slide shows the positive agreement or the proportion of patients who tested positive to specific IgE ELISA among patients who tested positive to the skin prick test. And you can see that coconut had the highest positive agreement, followed by Johnson grass, pigweed, and rice. The lowest here is wild daisy. And looking at the sensitization patterns of these patients, you can see that from the skin prick test, majority are actually polysensitized. It's around 93.8%. And for the specific IgE ELISA, the number of patients who were monosensitized were almost equal to that who were polysensitized. When we say polysensitized, they had positive results to more than one pollen extract. So we can see from our study that more patients had allergic rhinitis, and this could probably be due to a higher prevalence of allergic rhinitis in our country. Most are females and the age group 20 to 30 years. IgE sensitization was higher with a skin prick test compared to the specific IgE ELISA. And one reason for this may be the location of the IgE antibody. In the skin prick test, these are actually cell-bound IgE, while the specific IgE ELISA uses IgE levels in the circulation. So here you can see that when you introduce the allergen on the skin of the patient, it actually is recognized by an IgE antibody that is bound to the high affinity receptor of the mast cell, and this will trigger a cascade of reaction and cause the degranulation of this mast cell, releasing inflammatory mediators, particularly histamine, which will produce the wheal and flare reaction. While in specific IgE ELISA, we use the serum of the patient. The allergen is attached to the polystyrene plate, and when you add the serum of the patient, the antibody will bind to the allergen. And then when a second antibody is added, which is an anti-IgE antibody with an enzyme attached to it, the horseradish peroxidase, you have the enzyme there, and with the addition of a substrate, you have color change, which is detected through a spectrophotometer. The second reason why the skin prick test may have higher positivity rate or sensitization rate is because most tropical plants actually are highly glycosylated, and these glucose particles may mask the protein, the allergenic protein of the pollen grain. We saw also in our study that there are more polysensitized patients with a skin prick test. It's actually higher than that of studies in Germany and India, two countries where the flora is different from our country. So we could ask ourselves, what is the significance of a specific IgE test? When we do the skin prick test, we already have higher positivity rate. When you have several pollens which are positive, it's very difficult to do an allergen immunotherapy with so many pollen extracts. So specific IgE test may be helpful in the choice of the allergens for immunotherapy among these polysensitized patients, because some of these allergens may actually just be cross-reactive. So in conclusion, the sensitization profile of our local allergen extracts are similar to those in other countries in terms of higher detection through skin prick test than with the specific IgE ELISA. Filipino patients are mostly polysensitized, particularly with the skin prick test. Hence, future cross-reactivity studies would be helpful. And this is actually our next steps in the study. So these are references. Thank you for your kind attention. Thank you, Mian. To react on the two papers presented, may I call on the Chair of the Department of Clinical Epidemiology, Dr. Giorgio Mantay.
Thank you, Isan. And thank you to the presenters, and I would like to congratulate them for a very well done study and for the potential of your study for future researchers. I'd like to separate my reaction to the researchers. So I'll first react on Dr. Villanueva's research. Actually, the framework for my reaction is on the reporting standards. And for your study, which is an observational study, the reporting standard is the STROBE. I almost forgot. But I had forgotten what that acronym stands for, but it's the reporting standards. So first of all, as per the recommendation of the reporting standard, the study design should be part of your of your title. So siguro, you can put a pilot cohort study, and that will make it acceptable to international publications. Um, I have one disclaimer that yung presentation mo was different from what was given to me. The paper that was given to me, for example, no, didn't contain the objectives, didn't contain the specific objectives, and this is very important, especially since that's part of the reporting standards. And your general objective was in the abstract, and it was actually vague. You flashed the objectives very fast, but I was not able to appreciate what your actual specific objectives were. But I was going to make the suggestion that you should specify your outcome in your objectives. For example, you can put to determine the odds siguro, no, of mortality among those with the biomarkers of interest in a cohort of pediatric patients diagnosed with sepsis or sepsis. One of my important critiques about this study is that the age ranges of your patients are very heterogeneous. You have 1 month to 1 year, and then 2 to 5 years, 6 to 12, and 13 to 18. And I'm sure you will agree with me that the immune status of your adolescents are very different from that of the 1 month to 1 year. And my bias kasi is that I'm a neonatologist and I take care of babies, and I see sepsis all the time, and I feel that they're the most vulnerable, and perhaps in a future study, you can concentrate on those will most benefit from this study, which is the ones that are most susceptible to sepsis and septic shock. Either that, or in your modeling, kasi gagawa ka ng model, di ba? You include age siguro as part of the model. Kasi if definitely the younger ones, parang the prognostic model can adjust for age. Let's just say that. Other things that are in the strobe reporting standards is the need for a discussion of possible sources of bias and how this can be prevented. And I can see that there may be possible selection bias and performance bias. And since you had dropouts, then there can also be some attrition bias. Pero that will not naman invalidate the results of your study. It will just mean that you identify these limitations and you're accounting for them. Also, don't forget to justify your sample size. I think that's about it. Teka muna. Lastly pala, when you do prognostic studies, it's very important that there's a derivation cohort and later a validation cohort. You cannot validate your study with the same population that you used to derive the model. So I'm assuming that there will be another study that will be conducted wherein you can create your true model. And this is where I feel that we will really need a larger sample size. And I think you should consider creating a model where you can input all of these factors for your final prognosis, mortality or no mortality, which I feel can be addressed if you create a prognostic calculator for determining the risk of mortality among patients who are at risk of sepsis. By the way, no, yung manuscript na sinabit mo said they were diagnosed to have sepsis or septic shock. But when you presented, suspected, I think the inclusion should be patients with suspected sepsis, not those who are diagnosed with sepsis. Otherwise, that might be another source of selection bias. But overall, I think this is really a really great study. Actually, may konti akong kwento tungkol kay Dr. Villanueva. Nag-IFDP kasi si Emilio. And I was very impressed at at his performance for the IFDP module din ng research niya. And I found out that he had a master's in statistics. So I actually reached out to him and said, baka gusto mo magpa-cross-enroll sa Department of Clinical Epidemiology, kaya lang he politely declined. And for studies such as this, I think you should collaborate with those who can, the more people who will read your study, I think the better the study will become. So again, a call for collaboration. That even if you decline my invitation to join the department, you can still collaborate naman with us in future studies. So yun lang ang gusto kong sabihin. Okay, my next reaction is to that of Dr. Pastor from CM, who's a student of ours. My only disclaimer here is kasi that when I was made to react, they only gave me the abstract. And I had so many comments about the abstract, which were actually addressed when you made your actual presentation. So I think this is still exploratory. I'm not mistaken. It's a cross-sectional study that I thought was looking into whether there is reliability of the IgE antibody by ELISA with the skin prick test. No, that's not. So that, and I found out that's not pala. She just wanted to present a profile of patients, so purely descriptive. So with that, in my limited understanding kasi of the significance of the study based on the abstract, now I actually appreciate it more. And I feel that, again, being a pilot, there is a lot of potential for clinical use, especially in the area of I don't think the area you were actually targeting was diagnosis. Pero kasi in the conclusion of your abstract, you said that sensitivities and specificities will still have to be addressed in a future study. That's why I thought baka diagnostic. Pero now I better appreciate that it's actually one step to a bigger study, which is to look at which is being used to identify patients who can benefit from sensitization. Tama, no? Yan, buti na namin intindihan ko. The reason why I wanted to react to your comment in the abstract that it might be used for disease diagnosis, kasi sensitivities and specificities. I wanted to tell the audience that for diagnostic tests, there are phases for the development of diagnostic tests. So may phase 1 diagnostic test, phase 2, and phase 3. So malayo pa tayo to a phase 3 diagnostic test. And I thought that because this study only included those whose skin prick tests were positive, this would not even qualify for phase 1. But I think you allayed my apprehensions about making that comment kasi. And then I think that's about it. And I would like to congratulate both presenters kasi these are parang lifetime work and it will lead the way to more studies which can be used eventually for clinical utility. Thank you.
Thank you, Jojo, for the very helpful recommendations on how to enhance the methodology of the papers and the write-up, as these are exploratory and pilot studies. So, any questions from our audience? Yeah. So if none, then again, congratulations, Mian and Emilio. Yeah. So I look forward to, since these are exploratory pilot studies, the bigger studies, addressing all the objectives of the paper and then taking into account ways to improve the methods. Okay. So we'll move to the next session, which are, I think, papers that have some implications on health policy, health service delivery. So we start off with function-based rehabilitation model, an initial step towards universal health coverage, to be presented by Dr. Josephine Bondoc of the Department of Rehabilitation Medicine. Oh, okay. So Dr. Paloyo requested to present first. So we'll have outcomes of kidney transplants under the Philippine Health Insurance Corporation C benefit package at the UPPGH from 2015 to 2021. So Dr. Sigfredo Paloyo from the Department of Surgery.
Hi, good afternoon, and I'd like to thank the organizers for giving me a chance to present our work, from the Division of Transplant Surgery. Okay, so my talk is entitled "Outcomes of Kidney Transplants under the PhilHealth Z benefit package." From 2015 to 2021. So, I chose this slide because I'm not sure if you guys have heard of the recent sort of buzz, on transplant, wherein pigs' hearts and kidneys were transplanted, and they worked. They worked for a couple of months. So this sort of like encourage and sort of put xenotransplantation into the light. So anyway, so end-stage renal disease is considered one of the most burdensome diseases, particularly for us, low to middle income countries. It remains to be the second largest expenditure of field health. Although transplant is more cost effective versus dialysis, very seldom, very frequently, both of these are paid out of pocket, by patients. So to address this health inequity, PhilHealth launched the B benefit package for kidney transplant in 2012. I think it was also the same time they launched it for cabbage, and for breast and colon cancers. So that's for transplant, and they essentially they are subsidizing around $12,000 for the transplant, for the medications, and for the post-transplant laboratories for, I think, for 3 months. For 3 months. Now, the overall aim of the package is to increase the financial risk protection of its members, particularly the underprivileged. So PGH was contracted in later on, 2015, and since then we've been offering this to essentially low risk patients, low immunologic risk patients, low medical risk patients, and this is the criteria that we presently use. Just run it through them very quickly. So it has age of more than 10, first kidney transplant, no presence of antibodies, no history of cancer, no severe illness like CHF or cirrhosis or chronic lung disease. Of course, no any paralysis, mental incapacity, substance abuse. We don't transplant. We don't consider them if they are Hep C. If they're HIV, they should be on antiretroviral therapy, and the CD4 count should be low. I think more than 200 or less than 200. And hepatitis B should be, if ever it's positive, I should have a HBV DNA of less than 2,000. And if ever the donor is CMV, cytomegalovirus positive, and the recipient is negative, the patient will have to pay out of pocket the antiviral prophylaxis. It's
very expensive, this antiviral prophylaxis. So a box of Valsite, I think it's 90,000. So it last you a month, no? So you're gonna use it for like 3 to 6 months. So really, it's a big chunk of money. No? So PhilHealth doesn't support that yet. No? So that's the criteria that we use. Now for the data out there, no, the literature, actually there's not much, no, particularly for local data, no. NKTI, of course, published their experience way back in 2016. It's a lot of patients, actually 261 transplants, and considerable amount of them were from deceased donors. No? When you transplant patients from deceased donors, it's really very expensive. No? So, in fact, in this study of NKTI, these transplants, the ones from deceased donors, sort of they went over the budget. No, they were given the budget was around 12,000 US, so all of them went over the budget of 12,000. So it's really expensive. And then yeah, so they had immediate graft function, but they didn't report their graft survival or nor their patient survival. And just to give you an idea, in the US, this is the most recent data from 2020. You know, so if you can see 1 or 3 and even 5 year survival, it's really quite high. You know? More than 95% for 1 year and around for 3 years, maybe 90, 95, 93. And then for 5 years, around 80, 85. You know? So that's the data out there. Now for this study, we set out to review our experience, no, and outcomes with this benefit package. And we had all living donors, no? So we didn't have deceased donors. And all transplants has to pass the ethics committee of the hospital. No? So we did the chart review of 5 years of worth of data, and the social worker of PGH, no, classifies them to either no balance billing or copay. No? And then we use these statistical methods, and continuous and categorical variables were determined, as well as the Kaplan-Meier curve. No? So I'll just show them in a while. No? So these are our results. No, a total of 29 living donor kidney transplants, and the median age is around 34 for the recipient. You know, and pretty much same as far as gender is concerned, same numbers. Most of them have CGN, no, around 69, 70%. And a big chunk of them, 90%, are in copay category. So if you're classified as copay, you'll have to shell out additional 4,000 US. No? So that's around 600,000, no, 400 or 600,000 pesos, something like that. No? On top of the subsidy of PhilHealth. No? And then we did 3 NBD cases. No? So we didn't pay anything. No? So expectedly, most Filipinos are blood type O, and a good maybe half of them are within normal BMI. You know? For induction, no, this is we give induction or give medications prior to the transplant. Most of them got the thymoglobulin, which is a lymphocyte depleting agent. Around 38% of them have 5 to 6 mismatches. No? So in a way, they're considered a little higher than usual risk. No? CMV, most of them have antibodies. No? So positive, the donor is positive, the recipient is positive also. So they don't need to take the Valsite, no? The 90,000 peso per box medication. No? So around 90% of them. And 70% of them we use stents, no? to facilitate and to keep the patency of the anastomosis. Really, why we determined that is because it's been associated with higher putting stents. It's been associated with a higher number of urinary tract infection post-transplant. No? So that's why we tried to determine if you're doing that, if you're getting that. Ischemia time, the amount of time that the kidney is out of the body is around 32 minutes, which is usually around the normal or usual level range of time. No? Cold ischemia is the amount of time that the kidney is on the ice, no? Around 15 minutes, again within acceptable values. No? And the recipient usually stays around a week. No, they get admitted 2 days before, and then do the transplant, and then maybe a week they spend in the hospital. And then the median, no, creatinine discharge creatinine of the 29 patients is 1.04. It's really, I mean, it's good. No? It's excellent result. And as far as the graft survival is concerned, we had 100% graft survival 1 year, no? And then 96 for 2 years and 85% graft survival for 5 years. No? I think this is the longest survival, no, data out there. But again, you only have small sample size. No? So locally, I'm just saying locally. For going to the donor, no, the donor has the median age is around 28, no, almost a very young patients, no, and most were males, and again, most are blood type O, and around 60% were within normal BMI. Most of them are living related donors, no? And then commonly we get the right kidneys. No? The donor stays around 5-6 days in the hospital, and the discharge creatinine is around 1. So again, excellent outcome. Their survival at 1 year is 100%, and then 3 years 91, and 5 years 81%. Again, excellent patient survival. Now, for the complications that we noted, these were we had one patient who died, no, who had a functioning graft. 2 patients had UTI. 1 patient had acute rejection. 1 had steroid-induced gastropathy, and 1 had catheter-related bloodstream infection. And you can just imagine, because these patients are often, no, have long-standing catheters, no, so they're really prone to have bloodstream infection. And we had 1 patient, the donor, no, so medyo iba, no, the donor had the complication. So the donor had bleeding, so we had to do re-op on the donor, and in fact, the donor was even admitted to the ICU for a couple of days. But fortunately, he went home with very good kidney function, no other untoward incidents. No, I'm just saying that even if the donor, you can just imagine, no, we have 2 patients, and maybe the subsidy is, like I said, around 12,000 euros. You can just imagine the expense if we have to reoperate on a donor and put him in the ICU. I mean, in some hospitals, automatic, siguro, isang million siguro yun. But surprisingly, in PGH, even if the donor was reoperated, pasok pa rin sa budget, no? Pasok pa rin sa within the budget of PhilHealth. Hindi sa sumobra. So it's really, I mean, it's really surprising, because siyempre, PGH gives us, not expensive, laboratories, accommodations, no? So even private nurses, hindi ganun kamahal. So it's really noteworthy to mention that. So in this study, it's a single center experience with low risk patients with a median follow-up of 65 months. Again, pretty long. No? So with this package, even if it's no balance billing or copay, across the board, patients will get the same treatment. Patients will get the same accommodation. No? Same set of laboratories. No? They get the same immunosuppression they get, but later on, when the generic ones were available, so we started using generic. So parang medyo sort of nakatipid ng konti. we started using generic immunosuppression, but again, they're also effective now. So perhaps owing to the higher number of cases that we have mismatches that I mentioned before, we tend to use thymoglobulin more frequently. And so CMV, there was no CMV disease that developed, no? And this one, I mentioned this already, the total expenditure were all below the subsidy provider. So essentially, we delivered the service, kumita yung hospital, kumita rin siguro yung doktor, konti. So, but I mean, it's all wins since then. No? So, so again, probably because of good patient selection and optimal management, we were able to get these outcomes, no? And acceptable perioperative complications. No? So some recommendations, as with any program, of course, may mga unique issues and some are worth mentioning. So we need to embark on doing laparoscopic donors, no? So because in some centers they're already doing that. However, in TGH we haven't done that yet, so hopefully we can do that soon. We need to evaluate the cost of deceased donors. Like I said, it's very prohibitive. An organ, if you get from the national waiting list, I think they're going to ask you 300, 400,000 instantly. So just to keep that organ, alive. So wala pa yun yung transplant. And then we need to expand the criteria, no? The one that I showed you. Maybe include pediatric patients. Kasi yung nilabas ng pila, parang more than 10 years old lang. Pwede. But I mean, ang daming patients na pediatric, needing transplant. No? They're all in peritoneal dialysis. So anyway, we need to expand that. And I think we need to expand even patients who have second or even third kidney transplant. So bakit hindi? No? So anyway, so that's just my thought on that. And then we need to have a dedicated charity room. No? When you're NDB or your copay, you're admitted in the pay floor. No? Medyo yun yung unique scenario ng transplant. We've been lobbying for why not give them a room in, I don't know, one of the wards, isolated and everything. No? So we can free up the pay floors, no, for other patients. And total, NDB naman siya. I mean, we can, we can structurally do that. So somehow, wala pa. So anyway, so if you're NDB, you're still admitted in the pay floors. No? So we need some recommend we do cost analysis studies. No? Siyempre, kung magkano ba talaga kinita, whatever. No? Magkano natipid, magkano kinita, etc. And because of COVID, we need to determine kung ano yung COVID outcomes natin. No? Patients who had COVID pre-transplant or even COVID after transplant. So we don't know yet. No? We're still practicing in uncertainty. Kumbaga. So in conclusion, it has been almost a decade since still have embarked on this benefit package. And it seems it's achieving its goals, providing quality care, especially for poor, for the poor people who cannot afford a catastrophic disease like ESRD. No? So it's hoped that with this package, there's going to be increased awareness, among people at risk. Mahalaga na makuha natin, we get them, we capture them very early. Even if they haven't started dialysis, that's the best, actually best outcome. Preemptive. We get them preemptively, and then we get better survival. So we get better survival, we get better outcomes, we get cost effective. So yeah, so that's it. Thank you very much for your attention. That's it.
Thank you, Dr. Paloyo. So our next paper is function-based rehabilitation model, an initial step towards the universal healthcare coverage, to be presented by Dr. Penny Bundok, Department of Rehab Medicine.
Good afternoon. This presentation focuses on the development of a function-based model as an initial step towards universal health coverage for rehabilitation. This project, which was implemented by Physicians for Peace Philippines in collaboration with the Philippine General Hospital Department of Rehabilitation Medicine and the Philippine Academy of Rehabilitation Medicine, proved crucial in the formulation of the PhilHealth rehabilitation packages for adults through the support of PhilHealth and the Philippine Council for Health Research and Development. The Universal Healthcare Law provides coverage for individual-based health services, including ambulatory outpatient and inpatient care, medicines, laboratory tests, and procedures. Furthermore, it includes rehabilitative care through public, private, or mixed networks of primary care and hospitals. Rehabilitation is recognized as a cost-effective intervention that has the potential to reduce cost, increase gain in quality-adjusted life years in the long term, and reduce economic burden of health conditions. At present, there are PhilHealth benefit packages that provide coverage for rehabilitation services. However, the current coverage for adults only focuses on specific conditions and disabilities and at a limited extent. In order to respond to the need of providing coverage for rehabilitation services across different conditions or diagnoses, this paper focused on developing a framework to guide decision-making in designing PhilHealth benefits for adults warranting rehabilitation services. The paper utilized a qualitative methodology. Initially, epidemiological data and service delivery models were reviewed through scoping reviews. We also looked into PGH data to analyze the most common conditions requiring rehabilitation services. We then conducted key informal interviews with technical experts and professional groups involved in the delivery of rehabilitation services. Based on the results of these two steps, the project team developed a preliminary model for the delivery of rehabilitation services. This was followed by focus group discussions and consultation meetings to present, validate, and test the model. As a key consideration in the development of the model, the project team used the International Classification of Functioning Disability and Health as one of the key references in designing the framework. The ICF model is a paradigm shift from a purely medical model to integrating health within a biopsychosocial model of human functioning and disability. As a system of classification, the ICF groups different domains through functioning and disability and contextual factors. Based on the scoping review and recommendations from technical experts, 4 general categories were developed. These categories correspond to the etiologies of conditions as seen by rehabilitation medicine practitioners. Top diseases for each category that require rehabilitation were identified to guide the technical experts in enumerating potential diagnostic tests, medications, and rehabilitation services. Based on discussions between the study team and the technical experts, a framework or algorithm of care was developed. The unified pathway of care starts with the 4 disease categories initially identified. An impairment classification list was developed to identify the impairments seen in patients who will avail of proposed benefit packages. This impairment classification was adopted from the taxonomy of body functions or impairments of body functions from the ICF 2001, which covered 9 impairments. A single disease entity may cause variable impairments on different patients. For example, a stroke of similar etiology may cause intellectual and language impairments in one patient and cause only sensory impairment in another. Hence, other patients with the same disease condition may need different rehabilitation services. On the other hand, 2 different diseases such as diabetic foot and knee osteoarthritis can have the same musculoskeletal impairment of mobility and the same sensory impairment of pain and may need the same rehabilitation services. As part of the pathway, several radiologic and laboratory diagnostic tests were identified as essential services. However, these tests are not aimed at diagnosing the disease, but rather to help guide rehabilitation management, and determine functional outcomes. Our disability category and severity matrix was developed to guide the extent of management and therapy services that should be covered by the prototype benefit package. This would have an effect later on whether rehabilitation intervention is needed or not, and if needed, determine the potential number of sessions of therapy services and interventions that will be provided. Goals and outcomes are then evaluated in order to guide follow-up, discharge, and/or home instructions. This unified pathway that is anchored in a function-based approach guides rehabilitation assessment, management, prognostication, targeted outcomes, and care monitoring. It is envisioned that it will be used to simplify hospital service packages, community-based programs, and health insurance coverage. This study therefore provides an application of a function-based approach into actual practice, where diseases are classified in accordance with their consequent impairment and ensuing disabilities for harmonized management. This function-based approach has been taught in medical and allied health programs. However, its application is still primarily within rehabilitation medicine and allied health professional arenas. The four disability categories can serve as major groups of benefit packages in designing the proposed field health benefits. Each package already included diagnostic tests, clinical interventions on functional disease and participation while promoting enabling activities through holistic and multidisciplinary interventions. The ICF belongs to the WHO family of international classification, including ICD-10, used by the PhilHealth to classify diseases. In conclusion, this study provides a Philippine application of the ICF framework that harmonizes rehabilitation services and provides a framework for UHC. Likewise, this unified framework that utilizes impairment as basis for the delivery of rehabilitation services allow integration of patients into the health system across different levels of care. Through categorization of disabilities based on function, extent of management based on severity, and inclusion of essential management and intervention supported by outcomes evaluation, it serves as a good guide in the design and implementation of the PhilHealth insurance coverage for rehabilitative care. It is thus recommended that while the PhilHealth coverage for adults is being developed, individual professionals in rehabilitation care, hospitals, and healthcare networks have to be familiar with this framework and approach because its successful implementation will rely on the understanding of this function-based pathway of care that shall impact future policy formulation, referral systems, capacity building of service providers, and acceptance by both service providers and end users. Thank you for your kind attention, and we wish to acknowledge the valuable contributions of the following, whose collaboration and assistance have made this endeavor possible.
Thank you, Penny, for the presentation. So to react on the two papers, may I call on Dr. Lia Palileo Villanueva from the Department of Medicine and head of our COME unit.
Thank you, Ma'am Isa, for that introduction and for inviting me to react to these two papers. First, I'd like to congratulate Drs. Bundok and Paloyo and their collaborators for producing such research, which is not the usual type of research we do. And I think this is a signal that we are moving towards doing research that will help inform policy. And hopefully, when we do research that informs health policy, that would be down to better health outcomes for population at large. So I was asked to react on, I was asked to react on these two papers. Diyan, paano ako mag-slide forward? Okay. So the first paper that I will react to is Ma'am Penny's, because at the program, that was the first paper that was placed. And I think it was a very well-made paper. They used a qualitative research methodology, which is not also frequently familiar to everybody. So they developed a framework that will guide care and eventually maybe health coverage. And in developing this framework, they involved all stakeholders. I noticed it's not just the clinician or the practitioner and allied medical professionals, but they also looked at health facility administrators and patient groups. So this, I think that's one strength of this paper, is that the framework developed was already took into consideration the input from all important stakeholders, and that would hopefully lead to better people, better person-centered and not just patient-centered care. They also considered, I think, evidence. No, so I think that's one challenge. No, when we talk about knowledge translation. So they looked at evidence and they consulted important stakeholders, because these evidence-based guidelines need to be contextualized to the Philippine reality, to the Philippine setting. And I think that's another strength of this paper. And I think the other strength of this paper is that the framework developed harmonized different approaches to rehabilitation, and actually started with what the patient feels, which is impaired mobility, etc. So I think those are the strengths of the paper. There was one sentence in the paper that really struck me. To avoid confusion, the proper terminology had to be used. Discussion and semantics was inherent. Sometimes we're very loose with the terminology that we use, but at least in this framework, it was very clear that the terminologies that we use in these frameworks is very important. Are we using tests to diagnose or to prognosticate? Because the decision making, even for the clinician, will vary. The way we evaluate evidence will differ. So I think that was something that really struck me in the paper that Ma'am Penny had published. Some suggestions. What I thought could have strengthened the paper more, and maybe could be a topic of another paper, would be a report of the results of the qualitative analysis, the thematic analysis. It would be interesting to see where there were divergences and convergences in the input of the various stakeholders, because that would be helpful in further tailoring the framework as well as any policy that might come out of this framework. Yeah, so the others are like just a little technical, maybe about the triangulation, just some discussion on the triangulation, etc. So, but I think that could also be a function of the limited space in one article. So I would suggest that maybe you could write up, because we do need a lot more information of patient experiences and patient views and perspectives, so that we can really ensure patient-centered or person, and actually not just patient. I think we're already moving towards people-centered care. So congratulations, Ma'am Penny and team. And then for the second paper, si Don batchmate ko yun. So yeah, again, congratulations. So this is interesting. No, this is coming from a transplant surgeon. We don't usually expect such papers from the transplant surgeon, because they're really usually focused on the procedures, etc. And I think that was reflected in the paper. I think the way the paper was written was mostly clinical still. So it was really a descriptive study, and it was interesting to see how patients of PGH who were covered by PhilHealth Z package actually had good outcomes. No? So I think that's the strength of this paper. It showed what a proof of concept. Of course, we cannot generalize because it's a small sample size, it's a single center. And maybe that's something that you could add to your discussion, Don, when you publish this paper. Maybe a discussion on how being a single center, small sample size might limit the generalizability of the results. You could also maybe discuss the facility-related factors that you mentioned in your oral presentation, that the prices in PGH are much lower than private hospitals. So that might be the reason why the PhilHealth Z package for PGH was sufficient, whereas for private hospitals, it might not be sufficient. Another thing that you could probably discuss is talk about what happens next. After the surgery, PhilHealth covers the patient, but these patients would require lifelong immunosuppressive therapy, which are quite expensive. So maybe a recommendation would be for patients with chronic illnesses who need lifelong medication, the state has to think about how to cover long-term treatment. And this is particularly important because in this paper, the population were our young, potentially productive members of society on whom their families could really depend on. So kung pagalingin natin sila, hindi lang sila yung magbe-benefit, but their families as well. And then when they become economically productive members of their families, they become economically productive members of society, and that will lead to economic development as a whole. Other suggestions might be to talk about a little more about the costs of the procedure, just because I think the focus of the paper was supposed to be on like how well PhilHealth covers, how sufficient it is in covering the care necessary for KT, but the paper focused more on the clinical outcomes, clinical descriptions of the patients as well as their donors. So perhaps discussion of the costs covered and not covered by PhilHealth would strengthen your paper. And lastly, I would maybe make our conclusion, just temper our conclusion a bit, because again, as we said earlier, it's not generalizable and there are other factors that could be contributing to the sufficiency of this PhilHealth package in our PGH patients, which might not be applicable to more people outside. Just a note, one last thing I noticed here is that, yes, we said the patients included in the study were young, potentially productive, but I think they were also not the poorest of the poor. No, they were assessed by MSS to be able to afford co-pays. So that means they're not the poorest of the poor. So it makes me wonder if, I think to me it's very telling, one, of the poor utilization rate by the poorest of the poor. They're not able to utilize, they're not able to go to the hospital, etc. That's why they're not able to benefit from the PhilHealth Z package. So in terms of policy, maybe we need to think about how to expand that and really think about the poorest of the poor. In the Philippines, NCDs this costs a lot. Okay, and these two papers really focus on the NCDs, the complications of non-communicable diseases. So CKD from GN, but also other non-communicable diseases, and rehabilitation from a lot of non-communicable diseases. So maybe we need to also start focusing not just on acute infectious diseases, but also on non-communicable diseases, because non-communicable diseases affect the productive members of society. And they are the ones who will contribute most to economic development for the country. And I think that is the focus of the UHC law, which was signed into law, enacted in February of 2019. If you see here, they say that the law guarantees equitable access to quality and affordable healthcare services for all Filipinos. Then again, has it really done its job so far? The principles of the UHC law says that the guiding principles are that the state abides by the principle of everybody's right to health. And this would mean that the state will adopt integrated and comprehensive approach to health services, which spans the whole spectrum, no, from health promotion all the way to rehabilitation. So I think that's why this paper of Ma'am Penny is still relevant because of the UHC law. And I think it says here that we are going to be biased towards the population who cannot afford. And Don's paper showed us that so far the PhilHealth, some of the PhilHealth packages have not addressed the needs of those who cannot afford. The framework fosters a whole of system, whole of government, and whole of society approach. But so far, we're really just focusing on financing. In Ma'am Penny's paper, in her conclusion, she actually said, and in her discussion, she actually said, we also need to look at human resources, infrastructure, and other needs outside of the health system to make this work. And lastly, a people-oriented approach is necessary. And this people-centered approach should be centered on people's needs and well-being. So if you notice the semantics again, this is not patient, but people, because our patients are people with other concerns outside of just their illness. Yeah. So with that, I'd like to congratulate again the authors, both teams, and I hope that we will see more papers, similar papers, so that the college and the university will really fulfill its mandate to help inform policy that will lead to the betterment of the health of our people. Thank you.
Thank you very much, Leah, for highlighting the strength of the papers, especially the policy implications, and bringing us back to universal health care, and which is our goal as a country. And so with that, any questions from the audience or reactions or response from our presenters? Penny, would you like to react or respond? So we can see you also.
Thank you very much. Actually, we just came from an MOU signing with an LG, which is Pasig. So I apologize for being late. And I thank you, ma'am, for reacting regarding the divergence. Indeed, there was. There was a divergence in terms of the point of view of the service providers, the persons with disabilities, and the healthcare facilities. And then there was a lot of talk about how they could be integrated, how we could connect the service providers and the end users. So thank you for suggesting that. We have another paper in mind. Thank you.
Dr. Paloyo, you want to react? Emilio, I was not able to call you earlier. Okay, you want to react to the or respond to George's comments kanina? You have some time.
I would like to thank Dr. Mantaring's comment, and we will try to revise the manuscript according to the SOAP checklist to improve the reporting style.
Ni Ann, hindi ka natawag kanina.
Thank you for the comments. And we're actually trying to improve our extracts. That's why we're doing this study. And we're also starting to collaborate with the Asian region with regards the pollen extracts.
Thank you. So we've come to the end of the forum, but I'd like first to really thank and congratulate all our faculty researchers for sharing your impressive work. We're very happy with the output. So because I really tried to feature the spectrum of the work that is being done. So we can see that there's work in basic science, molecular research, health education, and then down to health policy papers that have impact on health policy and health service delivery. And then we have discoveries and innovations already also uh, blooming. No? So we really are appreciative, no, of your work, and your work highlights, no, how important collaborations and partnerships in addressing, answering the gaps, no, in healthcare, finding science-based solutions applicable to our setting, no, where we really need to do work in our setting to validate findings. So we look forward to the continuation and expansion of your work. We look forward to the patents, publications, the application of your results, no, moving them forward. And we're thankful to the reactors. Very insightful reactions, very helpful recommendations, suggestions on how to move forward, also not to uh, improve publication, and then also suggestions on methods. Okay, and then I think we've generated also more research questions to work on, to expand, to carry on the program as we aim to provide quality, affordable healthcare, and then also improve medical education, capacitate, our medical students and the faculty. And at last, I'd like to thank Diego and Mitch, my very efficient staff in RIDO, for organizing the forum. And then we have another research dissemination activity this December, the Science and Technology Week. December 5 is the slot assigned for UPCM and PGH again. So this time the papers that will be featured are those that present lessons learned from COVID. So we'll have a call again for papers on COVID, focusing on lessons learned. So these are the ones that will be presented in the Science and Technology Week in December. I think that's it. So we look forward to next year's research forum. Congratulations again, and thank you for staying on. Picture tayo.
Ito po.